keep on reading widely, or else you just become a cataract surgeon. And only a cataract surgeon. You know, shelling peas.
Yeah.
But now I have to behave myself, because undoubtedly at some stage we'll need the cataracts done. Webinar is now streaming live on the custom live streaming service.
We should be behaving.
That's what I was thinking, Ashok. If that's possible. What? Behave?
Dr. Sharma, are you still at the Institute?
No, I have come to Center for Sight.
Oh, okay. Okay.
Yeah. So it's a new chapter for me.
Wonderful. Great.
Milind, can you call Peter and just guide him?
I'll do that.
Because he seems to be getting nowhere. He's clicking on the link, but it's not going anywhere, he says.
Can you send the link that Namrata has sent?
Yeah, I sent him that too. I sent him that.
Okay.
He's saying can join from cell, but not. I'll just check with him.
From mobile, it only works if you make it horizontal.
Which one?
From mobile, if you want to join, it will only screen comes up if the mobile is held horizontally and not vertically. It clearly says you have to rotate the screen.
All right, sir. We are being given green signal. So I think we are about to start the session.
Mukesh, we can start.
Yeah, okay. It's indeed a matter of great pleasure for me to welcome you all today here in the AIOS International Ophthalmic session. And it's a great initiative, I must say, by Dr. Namrata Sharma and Dr. Santosh Honawar. And today we are having session on thyroid eye disease. In the session, we are having a galaxy of, just a minute, I'm trying to share my screen. It's taking a little bit. So in the session, we are having a galaxy of luminaries as chair, expert, and speakers. And to conduct the proceedings on the chair, we are having Dr. Usha Kim and Dr. Santosh Honawar as Dr. Usha Kim and Dr. Ashok Grover as chairpersons. Me and Dr. Kasturi will moderate the session, and we are also having Dr. Ferooj and Dr. Gunjan. They will be convener of the session. So I think since there is some problem in the screen sharing, so I'll be giving a brief for Dr. Kasturi Bhattacharya, who is also moderating the session. Dr. Kasturi is the director of Shri Shankardeva Netralaya, Guwahati, and she is also head of ophthalmoplasty and reconstructive surgeries there. Besides being the reviewer of many national and international journals, she is also member editor board of American Academy of Ophthalmology, AAO, INET, section editor for facial plastic and IJO. She is also the recipient of more than 38 prestigious awards for her work. She has been global examiner for FRCS Glasgow for 15 years and also past vice president of APS, OPRS, and past secretary of OPI. So Dr. Kasturi, please. I request Dr. Kasturi to introduce our chairpersons.
Yeah, can you see my slides?
Yes.
Let me make it full screen. So at the outset, I'd like to thank All India Ophthalmological Society, especially Dr. Namrata and Dr. Santosh Honowar, for arranging this beautiful international conference on thyroid eye disease. It is my great pleasure to introduce Dr. Usha Kim. Dr. Usha heads the Department of Orbit, Oculoplasty, Oculo-Oncology, and Oculoprosthesis at the Irvine Eye Hospitals, India. She is the current president of Oculoplastics Association of India. And Dr. Usha has contributed immensely in the field of oculoplasty and ocular cancer, both nationally and internationally. She had set the Ring of Hope initiative long back in the year 2004 to raise funds for the treatment of eye cancer. In addition to her core clinical work, Dr. Usha is involved in key leadership positions at the Irvine Eye Care Hospital. So Dr. Usha is one of the chairmen, and very much happy and honored to have you in this session. Along with Dr. Usha, we had Dr. Grover. Dr. Grover requires no introduction, but still I would like to mention that he is the recipient of the Padma Shri Award by the President of India and is the Chairman, Department of Ophthalmology, Sir Gangaram Hospital and the Vision Eye Centers, New Delhi. He is the present president of the SARC Oculoplastic Society and chairman of Specialty Education International Council of Ophthalmology. He has won prestigious awards and oration, chaired sessions, and conducted courses at various international oculoplasty and ophthalmology forums, and has been the past president of All India Ophthalmological Society and the past president of Oculoplastics Association of India. So I request Dr. Grover and Dr. Usha to kindly chair the sessions. Now I request Dr. Mukesh to kindly introduce the conveners of the sessions.
All right. So in the session, we are having two beautiful ladies as our convener, very bright oculoplasty surgeons. Dr. Feroz PM, she heads the Department of Orbit and Oculoplasty and also Managing Director at Horos Specialty Eye Care. She is a trained oculoplasty surgeon from LV Prasad Eye Institute and also from Wills Eye Hospital, Philadelphia. Her interest area includes orbit, eyelid, ocular surface disorder, dacryology, trauma, and aesthetic surgery. We are also having another very young ophthalmoplastic surgeon, Dr. Gunjan Saluja, as our another convener. She is currently working as senior resident in Strabismus Neuro-Ophthalmology and Oculoplastic Services at Dr. RP Center of Ophthalmological Sciences, AIMS, New Delhi. She also did her MD from the same institute. She has got 16 publications in various national and international journals, which I think a great feat at her level. She has written chapters in various books also. Over to you, Dr. Kasturi.
Yeah, I think we'll be starting the sessions, but before that, Gunjan, would you like to introduce the moderators of the session, please?
So I would like to introduce the moderators of the session. So our moderators today, as Mukesh sir has already introduced, Kasturi ma'am, who heads the oculoplasty and oculofacial aesthetics department at Sri Shankradeva Nethralaya. And besides being the reviewer of many national and international journals, ma'am is the member of editorial board of American Academy of Ophthalmology and has received more than 38 prestigious awards for her work in the field of ophthalmology. Our second moderator today evening is Dr. Mukesh Sharma sir, who is the director of Center for Sight Jaipur and specializes in orbit, ophthalmic plastic and reconstructive surgery. Sir is currently the secretary of Oculoplastic Association of India and has won numerous awards in various conferences. He has special interest in pediatric ophthalmology and oculoplasty surgery. Thank you.
So with this, we'll be starting the session. And before we start the session, it is my great honor and privilege to introduce the first speaker of today's session. The first speaker of today's session is Dr. Peter Doleman. Again, I'd like to mention that Dr. Doleman requires no introduction, but still I'd like to mention that he's a clinical professor of oculoplastics and orbit at the University of British Columbia, Vancouver, Canada. He's the past president of the International Thyroid Eye Disease Society and a member of the Orbit Society and International Consortium of the Orbit Experts. He has volunteered as a surgeon and lecturer in over 30 developing nations and has received several departmental research and teaching awards, the prestigious AIOS Research Award, and the Queen Elizabeth Gold Medal for the community service. Over to you, Dr. Doleman, please. I think Dr. Peter Doleman is having trouble in joining the session.
He's joined.
Oh, he has joined. Dr. Peter, please.
Hello, thank you, Kasturi, and can you hear me?
Mm-hmm. Yes, yes.
And is the screen up?
Yes.
Okay, thank you so much, Kasturi, for your nice introduction, and to the organizers of this symposium. And good evening to everybody watching. My task was to talk on how I evaluate severity and activity of thyroid eye disease. And in doing that assessment, how we ultimately manage this troubling condition. And my only disclosure is that I'm an unfunded investigator and consultant for Immunovant. As we know, thyroid eye disease is the most common orbital disease worldwide. It's an autoimmune process that causes inflammation, expansion, and in some cases scarring of orbital soft tissues, including the orbital fat, the extraocular muscles, the levator muscle, and lacrimal gland. These soft tissue changes can lead to significant visual and cosmetic morbidity, which impacts work, social life, and quality of life. One of the challenges with this is, can I minimize this screen here? There. One of the challenges with this disease, because of the broad spectrum of clinical manifestations, is how we actually catalog these different soft tissue changes and their severity, how we monitor the course of the disease and choose appropriate management. And that's the focus of this talk. Well, what is the concept of disease severity? That refers to the different anatomic and functional changes that result in the orbit as a result of the soft tissue damage from the immune process, monitoring both the severity, but also the activity. In other words, where in the immune process this is. In my practice, 2/3 of patients roughly have primarily orbital fat expansion with potential levator muscle tightening, causing eyelid retraction and proptosis and exposure symptoms and signs. These patients usually are young, have a very indolent onset without much soft tissue congestion or inflammation, are not necessarily smokers, but can lead nonetheless to quite severe alterations in their appearance. At the other end of the spectrum are those more severely affected functionally, and these have one or more of the extraocular muscles enlarged and inflamed. And the swelling of these muscles can lead to congestion of the orbital venous drainage, leading to inflammatory soft tissue changes or congestive changes, as well as restriction in motility. And in those cases where the nerve can be compressed in the tight orbital apex by these swollen muscles, may lead to vision loss from optic nerve compression. This latter group is typically are older patients, more equal gender distribution. The fat expansion group primarily is female to male 5:1 ratio, whereas this muscle expansion group is a more equal gender distribution. And this has a very rapid onset, which is easily documented by the patient and the clinician more acutely, also associated with smoking and a family history. And this latter mild genic group, or myopathic group, have a very obvious biphasic course, as described by Rundle back in the 1940s. The active phase consists of progressive deterioration in symptoms and signs relating to the orbit, which can last anywhere from half to 1.5 years before the disease eventually dies down, or the immune process dies down, but the patient is often left with significant orbital sequelae. The hope in these cases is to identify this severe group early on in the process and offer immunotherapy or radiotherapy to interfere with that immune cascade and hopefully result in fewer severe visual and functional changes. Only once the disease has stabilized do we usually consider surgical rehabilitation, although the exception is in cases where vision is threatened from corneal breakdown or from optic nerve compression, in which case surgery may be offered even early in the active phase to try and reverse the process. As you can see, then, it's important we not only determine the severity of the disease, the different clinical features and how badly the patient is affected, but also the course of the disease, whether we're going to offer medical therapy or radiotherapy or potentially surgery. Well, what are the strategies for grading severity? The common one used particularly amongst endocrinologists is the European Group of Graves Orbitopathy, or UGOGO system. They grade mild, moderate, severe, and very severe based largely on treatment categories. This is quite helpful for referral. So moderate to severe often are treated medically or referred to a center where medicines are chosen, and sight-threatening conditions, which are the very severe ones, may require surgery. However, I think there are limitations with this, with the system. One is that the terminology often ignores the patient perspective. For example, someone that might be called mild because they've got proptosis of 24 millimeters and lid retraction may still be very severely bothered or impacted by their disease. And likewise, someone at the other end of the spectrum who has optic neuropathy that only manifests with some mild color vision change wouldn't really consider themselves necessarily very severely affected. Also, there are mixed clinical features within the groups. So proptosis, for example, can appear in all three groups. And I think a system, this confuses management potentially. For example, moderate to severe, often the management systems using this UGOGO system recommends steroid therapy. Proptosis, for example, doesn't work well or doesn't respond well to corticosteroids. What about existing activity measures? Well, I think most of you will be familiar with the clinical activity score introduced by the Amsterdam group. This gives a 1 point for lid or conjunctival redness, lid conjunctival or caruncular edema or pain, and an additional point on follow-up visits if there's a measurable deterioration in vision, proptosis, or motility. This is a quick, easy scoring system. It was devised to predict responsiveness to corticosteroids, which was the available treatment at the time. And generally, it can be used as a surrogate marker for inflammatory activity. But there are limitations. It's a binary scale, so you can have a measurable or an obvious improvement, let's say in chemosis, but still have a little chemosis, and that doesn't reflect as improvement in the score. There's an equal weight for each variable. So someone, for example, may have a drop in 5 lines in vision, and that only gets a point in the CAS score, as well as someone who just has some mild injection one day from dry eye. And it's uncertain if the clinical activity score actually predicts any progression in disease. There are also important false negatives and positives to be aware of. I mentioned the lipogenic phenotype without much extraocular muscle involvement. These patients may develop quite marked proptosis and lid retraction without ever developing a significant CAS score. And also another group are East Asian patients who may develop quite striking extraocular muscle at the apex, leading to severe vision loss from optic neuropathy, often with, again, very little evidence of inflammatory soft tissue changes. And then there are some false positives. This patient was on the corticosteroids and Cellcept for a year and a half, trying to treat congestion when she was referred to me, but in fact had no progressive disease by history. She really was just congested because of swollen muscles, and simple surgery and discontinuation of all her medicines was possible. I prefer actually a system of grading activity based more on the clinical course of the disease, documenting, is it a brief duration, has there been a rapid rate of onset, and specifically both from the patient perspective and the clinician measuring from visit to visit, whether you can measure actual changes in any one of the severity parameters. And you can corroborate that with changes in TSH receptor antibodies and imaging support. Contrast CT on this example shows active disease on the patient's left orbit and old quiescent swollen muscles from a previous attack on the right side, where you have hypolucent, non-contrast enhanced muscles. Likewise on T2 or stir-weighted MRI, you can see enhancement often in the active muscles from inflammatory edema. I'll introduce the VISA classification, which ITEDS has adopted and which Jack Rubin and I introduced in 2006, which tries to record severity and activity in one clinical recording form, and focuses on 4 disease severity parameters. So it divides the disease into vision or optic neuropathy, inflammation, congestion, soft tissue changes, strabismus, including diplopia, and appearance exposure changes. It has both the patient's subjective input for each of these, as well as measurable changes. For example, in vision, you'd record the central vision, color vision, pupil response, appearance of the optic nerve, all clustered within that particular parameter. And then you can, at the bottom of the sheet, for each parameter, determine whether they're mild, moderately, or severely affected. And in terms of activity, not base this on any soft tissue score, but whether there has been subjective or objective progression in any one of these parameters. So for example, if someone has optic neuropathy, we try to rule that out first. Subjectively, we ask about vision loss, faded colors. Objectively, we measure the signs suggestive of optic nerve compression. We can support it with visual fields and a coronal CT scan in the case of compressive optic neuropathy. And if present, then choose selective management. For each one of the severity parameters, after you've determined whether they have features and how severely they're affected, you can then ask, are they progressive or not? Are they active or not? In optic neuropathy, they typically are active when they declare themselves. In this case, corticosteroids and radiotherapy have both been shown by a number of studies to be effective for this condition. Optic neuropathy can even be avoided if radiotherapy is offered early. And in cases where medical or radiotherapy is ineffective or insufficient, you can consider surgical decompression, expanding the orbit into the adjoining sinus and relieving pressure on the nerve. The inflammation congestion score refers to any soft tissue change. And remember, that may not just be inflammation representing activity, but we pointed out you could have passive congestion from long-standing muscle swelling with the disease already having died out, or you can have exposure change without progression, but just damage on the surface from poor lid closure and proptosis. So in this system, we look at these soft tissue changes not as an activity score like CAS with an absolute number, but rather as a feature of the disease or a severity parameter. And activity really would be looked at as a worsening in the VISA score, whether it's the inflammation, the vision, strabismus, or appearance. You can see the VISA score is based completely on the CAS score, with the slight change that lid edema and conjunctival edema are measured on a 3-point score to reflect a measurable improvement or worsening. So again, if someone presents with a lot of soft tissue scores, you can grade that using the VISA score, similar to the CAS score, but ask whether it's recent onset or progressive or document it. If it is recent onset and getting worse, then we can do the usual measures. And this is the large category where the various medical options are available to interfere with targeted parts of the immune pathway, which will be discussed shortly. So corticosteroids, radiotherapy, and the newer biologic agents such as tocilizumab and teprotumumab are all possibilities in this myogenic, more severe group, not only to try to avoid the onset of things like strabismus or optic neuropathy, but to reverse them. Notice that steroids and radiotherapy are very good at reversing congestion and swelling, but do not have much effect on lid retraction and don't generally have much effect on proptosis, unlike some of the newer agents like teprotumumab. If a patient has long-standing disease, however, and if there's no progression, this is a sign not of activity, but rather chronic muscle congestion of the venous drainage. And here, medicines won't be useful, but rather orbital decompression will restore the patient's or improve the patient's situation. The last two groups are strabismus and appearance. Strabismus and diplopia are the worst manifestations of the disease according to most quality of life surveys. Diplopia can be measured on the Von-Gorman scale, that is diplopia only with gaze, diplopia intermittently, or the worst case diplopia at primary. Objectively, if you want to measure ductions, a useful technique is to use a light pupil reflex where the light is shone in the eye. As a patient looks up, if it hits the limbus, it's 45. If it hits the edge of the pupil, 15, and halfway between is 30 degrees. And this is very reproducible in multi-center studies. Again, once you've documented the severity, how bad the strabismus is or how bad the ductions are, determine if they're in a progressive phase based on any change in the VISA parameters. If so, then patch, prisms, and various immunomodulators, steroids plus radiotherapy, teprotumumab or tocilizumab if available. But once the disease has reached a stable point, typically surgery or patches or prisms are offered to try to realign the patient. Finally, appearance exposure changes. This may be both because of myopathic disease or at the other end of the spectrum, the lipogenic fat expansion with lid retraction. In these cases, again, if they are in a progressive change with progressive worsening in the lid retraction or proptosis or swelling of the levator with contrast enhancement showing that this muscle is being targeted, then you could consider subconjunctival corticosteroid into the area of the levator has been shown helpful at lowering the lid. Selenium has shown some benefit in lid retraction. And most interestingly, recently, teprotumumab seems to, in this lipogenic group, even reverse proptosis and fat expansion potentially. ultimately, many of these patients, nonetheless, in spite of therapy, will benefit mostly from surgery. Unfortunately, the surgical results can be very positive. So I'll finish by saying it's important in assessing our patients to determine their severity, that is, what features of the disease they have and how badly they're affected. And in the VISA system, that would be vision, inflammation, strabismus, and appearance. Recognize if they're in the myopathic group, in which case they're more likely to get serious complications like vision loss or double vision. And within each cluster, is it progressive or is it active or inactive? Activity being defined primarily by progression in disease. And here the various corticosteroid, radiotherapy, and the newer immunomodulators, targeted immune therapy are offered in the progressive phase in all of these categories. But once they've reached stable phase, surgery is offered. And the last category, appearance, typically progressively, we treat conservatively, but once stable, would consider decompression and lid surgery. Thank you very much.
Thank you, Dr. Peter, very much. It was an excellent talk. There are two questions for you. Can I put the questions for you, please?
Sure.
One is Dr. Vatsala. She wants to know that in case of acute active progressive phase, what is your first line of treatment? It is whether it is steroid, radiotherapy, or the immunobiologicals.
We tend to use, if you're seeing the patient and they are in a high-risk group, so that you know that the muscles are involved. Typically, you can recognize them demographically because they'll be older, acute onset of disease, very often will have congestion, and the CT scan confirms it. If they've got anything suggestive of muscle involvement, then I typically will give a trial of oral prednisone just for a few days until we can organize pulse intravenous corticosteroid therapy. And very often we'll consider offering radiotherapy as well early on in that phase. Radiotherapy does not work well for proptosis or lid retraction, but we have shown, and other studies have shown, that it can prevent, in cases of these acute progressive phases, can reduce the risk of developing optic neuropathy and strabismus. In terms of newer agents, if you have failures, we have used tocilizumab. Teprotumumab is not available for us in Canada. So I will wait for other speakers to talk on that.
That's great. Thank you, Dr. Peter. There's another question, very interesting question from Dr. Aditi Mehta. She has mentioned that since fat expansion subtypes doesn't follow the Rundle curve, how early can we do surgery in that subgroup? Patients having the fat expansion, which doesn't follow the Rundle curve.
Yeah, it may follow Rundle's curve to some extent. It's just not so obvious. Very often patients are unaware that they're gradually developing proptosis. Often it might be their friends or family noticing and pointing out that they're bulging. Very often they're misdiagnosed by clinicians because they've got pink eye or dry eye complaints. But in those cases, we really depend on duration. So if it's been present for a year or a year and a half, and they say nothing has changed over the last 2 months or 3 months, then I think you can offer surgery fairly quickly. I am always quite reassuring to these patients. They're typically younger, more likely women, and they'll present with prominent eyes and lid retraction and very bothered by their condition. But you can usually be quite reassuring and say it's unlikely you're going to develop double vision or develop optic neuropathy because you're not in that group, that more severe myogenic phenotype. And so if you've seen them, if they've very acutely presenting, then I would wait and monitor them to watch to see if anything is changing. There is one exception that is lid retraction. where you have a swollen lid, an acute onset of lid retraction, and imaging shows edema in the levator, those patients actually can respond to Kenalog injections or triamcinolone injection around the levator muscle. But otherwise, most of them turn out to be surgical.
I have a question for you, Dr. Peter. Do you feel that every case follows the Randall's curve? Like, I believe there are cases where you do get relapses once you feel like disease has been stabilized, but after some time there are the possibility of relapse in these kind of cases. So how do you titrate every case? Like when do you feel that now disease is almost inactive and one can go for surgery? Like, is there?
You know, I think you're absolutely right. Rundle's curve is kind of a simplified concept, but I think it was still a very good observation that the disease does tend to burn itself out, particularly in the muscle type. And there can be sort of fluctuations during the progressive phase. There can also be recurrences late on. I mean, we definitely see people that have more than one attack 10, 15 years later, often associated with some stressor like a bad intercurrent infection or some personal stressor like a breakup in the family or a death or loss of job. I essentially, you know, anytime you do surgery like a decompression or strabismus surgery, there is a chance you can also reactivate the disease by performing the surgery. But generally, if someone is in the lipogenic type of category and has just fat expansion with proptosis, very little muscle involvement, and some lid retraction, I'm usually fairly comfortable if it's been half a year or a year to just go ahead and do surgery in those cases. And in the other cases that are more aggressive and progressive with a lot of congestive features, usually we're treating medically. And I typically will give, if I can, 6 months. As long as there's no sight-threatening issue, I'll give 6 months of quiet, stable phase before we go and consider decompression or alignment surgery. You can never be sure, and I always warn patients there's a small risk with any surgical intervention that we may actually aggravate the situation and re-stimulate the immune process. But I will typically, in decompressions and strabismus, consider covering also with a brief course of corticosteroid around the time of surgery.
Thank you, Dr. Peter. Now I'd like to request Dr. Mukesh to kindly introduce our next speaker, please.
Well, our next speaker is dynamic Dr. Santosh Honawar. Dr. Santosh Honawar is the editor of IGO in the Indian Journal of Ophthalmology. He is also director of medical services at Center for Sight, Hyderabad, and also head of Department of Ocular Oncology and Oculoplasty there. He has received many prestigious awards like Shanti Sharoop Bhatnagar Prize for Science and Technology, and also Lifetime Achievement very recently by American Academy of Ophthalmology. He is serving as Scientific Program Coordinator for OPI and also past Secretary of OPI. So we all look forward to hear him today on protocol of medical management of thyroid eye disease. Dr. Santosh, please.
Thank you, Mukesh, for the nice introduction. I'll share my screen. Is the screen visible?
Yes.
Okay. I'll be talking about medical management of thyroid eye disease. Peter has given a very beautiful introduction about the evaluation of activity and severity. Ultimately, we consider thyroid eye disease like a house on fire. And of course, as was pointed out, many patients may not be on the Rundle's curve, but that is the most common generalization that we have based on activity and severity. Patients can plot it at some point in the curve, and we follow them up over a period of time, and each patient gets his own curve ultimately, and that will guide us on how to treat them. Activity is always a measure of inflammation, and following active disease for several months or years, there are functional damages, functional or cosmetic deficit that are as a result of fibrosis, and that sets in. Now, measurement of activity is mainly based on clinical activity score. There are other measures as well. Clinical activity score of more than 3 at the primary visit or more than 4 on follow-up on 10 can predict activity. Whereas severity is based on UGOGO, mild is with minimum impact on patient's life, where there would be minor lid retraction, mild soft tissue involvement, exophthalmos of less than 3 millimeter, transient or no diplopia, or corneal exposure responsive to topical lubricants alone. Whereas if the patient has no imminent threat to sight, but has exophthalmos of more than 3 millimeter, inconstant or constant diplopia in functional positions of gaze, and moderate to severe soft tissue involvement or eyelid retraction of more than 2 millimeter are categorized as UGOGO moderate to severe thyroid eye disease. Very severe or sight-threatening are the ones who have imminent threat to vision with dysthyroid optic neuropathy or risk of corneal breakdown due to severe exposure. Now, management takes all this into consideration. When severity is mild, moderate, or severe, but the disease has been inactive for more than 6 months, then there is no controversy. However, timing is the key. In the interim period where you wait for 6 months for stability, you cover the patients with symptomatic or conservative management. Lifestyle modification, especially cessation of smoking, is supposed to help. Also, achieving stable euthyroid status by good thyroid control. Use of selenium is controversial, but it is supposed to help in patients who have had a recent onset mild disease in minimizing the risk of progression, or it can also work on eyelid retraction. 100 microgram twice a day for 6 months is the dose that is given. Then, of course, you perform sequential surgery, decompression, squint surgery, and eyelid. Primary medical management is specifically for this category of patients who have active disease, mild severity, but have active disease and with impaired quality of life. These can be chosen for medical management, and it's specifically chosen for moderate to severe disease or sight-threatening disease. Patients having symptomatic exophthalmos, disabling diplopia in primary position and down gaze, moderate to severe soft tissue signs, corneal exposure which is not responding to lubricants, and compressive optic neuropathy. Medical management is also indicated in the form of low or full dose oral steroid prophylaxis for patients who are supposed to undergo radioiodine. Now, there are several ways of medical management in active disease. General measures, of course, which I already enumerated. Oral steroids are indicated, and as opposed to intravenous steroids, you can see that oral steroids have a beneficial role in 30% of patients, whereas they have side effects which are considerable in 70% of patients. Whereas if you consider intravenous methylprednisolone or intravenous steroids, they benefit about 60 to 70% of patients. In about 30 to 40% of patients, they have side effects. So intravenous methylprednisolone is preferred. Intraorbital steroids are used when you're tapering off a patient on steroids or for mild recurrences. They also help minimize the activity in a particular eye where this injection is given. Triamcinolone is typically used. Immuno Modulators, immunobiologicals are the next line in therapy, and immunobiologicals may come in as a primary therapy over a period of time, and there is radiotherapy. This is UGOGO recommended pulse intravenous methylprednisolone therapy, where the cumulative dose is either 4.5 grams or 7.5 grams, depending on the activity. Now, if a patient has activity but not very severe, then you start off on 500 milligram every week for 6 weeks. That is 3 gram. That is followed by 250 milligram every week for another 6 weeks. So it's a cumulative dose of 4.5 gram. If it's more severe, then you start off with a higher dose of 750 milligram for 6 weeks, followed by 500 milligram for 6 more weeks. So totally about 3 months of treatment, and the cumulative dose there is 7.5 gram. We follow a low-dose intravenous methylprednisolone protocol, which is given 3 weekly. So as opposed to Yugogo, this is a 3 weekly pulse therapy, and the total cumulative dose is only 4 grams. So lower the dose of intravenous methylprednisolone, lower is the side effects. That is a presumption. And giving a gap of at least 3 weeks between each pulse helps in minimizing complications. And we go by chemotherapy logic, where every pulse takes away about 60 to 70% of activated T lymphocytes. So the regeneration time for activated T lymphocytes is about 2 to 3 weeks. So timing is possibly the key. Giving weekly intravenous methylprednisolone has slightly lower efficacy in our experience as compared to 3 weekly intravenous methylprednisolone. Here we begin with a loading dose of 500 milligram every day for 3 days. That is pulse 1, followed by 3 weekly pulse of 500 milligram for 6 pulses. That's about 4.5 months of treatment. And sometimes at pulse 4, we bring in immunomodulators, which are either azathioprine, mycophenolate of mofetil, or methotrexate. Immunomodulators can be steroid sparing, and they very gently handshake with the intravenous methylprednisolone. As we withdraw IVMP, immunomodulation would have started taking effect. We look at 3 endpoints. One is exophthalmos, extraocular motility restriction, and disease activity. This is an example of a patient. This is the appearance pre-treatment, and this is after 6 pulses of intravenous methylprednisolone. You can see that activity has minimized, and so has her exophthalmos. Not very remarkable, but there is appreciable reduction in exophthalmos. This is an asymmetrical thyroid disease where this patient manifested with severe exophthalmos in the right eye, and after 6 pulses of intravenous methylprednisolone and oral azathioprine, his activity has come down, and so has exophthalmos. One more similar example of a patient with low-dose intravenous methylprednisolone followed by 6 months of oral azathioprine, activity and exophthalmos and retraction all have come down. In our series of 117 eyes of 81 patients, we found mean improvement in exophthalmos of 2.7 millimeter. About 60% of patients had improvement of more than or equal to 3 millimeter. Ocular motility and diplopia, you can see in this patient that his left eye is not moving much in upgaze, whereas following intravenous methylprednisolone pulse therapy, eye movement has improved and his diplopia has settled down, and he also had reduction in eyelid retraction. This patient remarkably benefited by intravenous methylprednisolone and azathioprine. You can see that she had manifest strabismus here with severe diplopia. Following treatment, her eye has normalized in position and her diplopia has alleviated. One more example of a patient where there was restricted motility in upgaze with consequent diplopia, which has normalized following treatment. And you can look at the CT scan of the same patient. This is pre-treatment appearance, and this is post-treatment reduction in the thickness of inferior rectus muscle. One more patient where the right eye has difficulty in moving down and normalized following intravenous methylprednisolone and oral mycophenolate mofetil, and diplopia has got alleviated. About 60% of patients in our series benefited by reduction or improvement in diplopia in primary position and in down gaze by intravenous methylprednisolone low-dose pulse therapy followed by immunomodulation. Coming to remission of disease activity, this patient has benefited both in terms of exophthalmos and disease activity by IVMP and azathioprine. This patient needed rituximab and he was not willing for surgery, and his disease activity has minimized but not completely gone. We found that about 90% of patients have remission from disease activity with intravenous methylprednisolone pulse therapy and immunomodulation. Clinical activity score came down from 7.1 to begin with to 1.2 following treatment. And as compared to oral prednisolone alone or intravenous methylprednisolone alone in published series, combining IVMP with immunomodulation seems to have a beneficial effect. In patients with Yugogo severity, sight threatening, where there is imminent threat to vision or dysteroid optic neuropathy, there is a high dose protocol where you begin with 500 to 1000 milligram every day for 3 days and followed by a weekly injection of the same dose. At the end of 2 weeks, you decide if the patient is responding to treatment. You continue as was described for moderate to severe severity. But if there is no improvement in 2 weeks, or if there is recent onset choroidal folds or luxation of the eye which is not responding to conservative treatment, then prompt decompression is advocated. This is a patient who came with dysteroid optic neuropathy and severe chemosis. That was his appearance of extraocular muscle. Following 2 weeks of treatment and a gentle extreme temporal suture tarsophy, he responded quite dramatically. But in patients who have persistent choroidal folds of this sort, which does not respond to, although his optic disc congestion, optic disc edema has responded, choroidal folds have remained persistent, there is an argument for early orbital decompression. There are new firefighting techniques in the form of biologicals, which of course the next speaker is going to speak about. Biologicals are many, and it all depends on which receptor are you targeting. Anti-CD20 is rituximab, which is very commonly available in India. Anti-tumor necrosis factor inhibitor drugs are etanercept and infliximab, and there are anti-IL-6 receptor inhibitors, and the new kid on the block is teprotumumab, about which there is the next talk. This is a patient who benefited with rituximab, but not very remarkably. This patient had already received intravenous methylprednisolone and azathioprine. Following rituximab treatment, her right eye, which was in fixed ESO, has kind of started moving just a little bit. So rituximab helps, but not so much. Whereas in young individuals, rituximab seems to work much better. This was a young individual with rather asymmetric thyroid eye disease. Right eye is inflamed and active. Following rituximab, 2 injections of 500 milligram at 2 weekly interval, his activity had a remission and his exophthalmos also reduced remarkably. For patients with eyelid retraction, levator recession is advocated, but they always have complained that their lid crease is not symmetrical. Like this patient has a good correction, but her lid crease is not symmetrical and some amount of flattening of the lid contour. They're not very happy with it. So we use in subconjunctival triamcinolone very close to the levator aponeurosis in these patients with good effect. This is a patient who has received 2 injections of subconjunctival triamcinolone, 2 injections 6 weekly apart for her lid retraction, and she has normalized. One more similar patient where there was bilateral lid retraction, which responded to 2 injections of triamcinolone 2 months apart. This is a patient with unilateral severe lid retraction, which has come down. She also had difficulty in extraocular motility, so we injected triamcinolone close to her inferior rectors and medial rectors, and her motility also seems to have improved following this injection. You can see restricted motility here, which is kind of improved after 2 injections of triamcinolone close to her inflamed inferior rectus muscle. So this is the management protocol that we follow. If it's a mild thyroid eye disease, then control thyroid status, use selenium in recent onset mild disease, use lubricants, non-steroidal anti-inflammatory and oral steroids, quit smoking, intra-LPS steroids for eyelid retraction, and then you observe the patient. If the patient has quality of life issues and you need to treat, then you can start these patients on either oral steroids or low-dose IVMP pulse therapy. If they have functional deficit, then you start them on sequential surgery. In moderate to severe thyroid eye disease, you start with low-dose intravenous methylprednisolone pulse therapy. If there is good sustained response, you simply observe and sequentially perform surgery. If the response is suboptimal, then you can consider intraorbital steroids, low-dose radiation, or maintenance systemic immunosuppressants or immunobiologicals. In patients with severe sight-threatening disease, we begin with high-dose intravenous methylprednisolone pulse therapy. If there is good response in 2 weeks, you can maintain them on systemic immunosuppressants or immunobiologicals and do sequential surgery. If there is suboptimal response, then of course you have to prioritize them for early orbital decompression. This is a summation of published data where you find that if the disease is inactive at the time of surgery with prior primary medical treatment, then recurrence of disease activity is only 2 to 15% if you were to do decompression. Whereas if the patient were to have active disease at surgery without prior medical treatment, then the chance of disease activity recurrence is 24 to 40%. So there's a substantial increase in recurrence in disease activity following surgery if the patient were to be active at the time of orbital decompression and if the patient has not been pre-treated with intravenous methylprednisolone. So in summary, I would say that medical management of TED is indicated as primary management in moderate to severe active TED and severe active disease with threat provision. Intravenous methylprednisolone, oral immunomodulation, and rituximab have been the escalating approach, but with immunobiologicals in the picture, we might have a totally changed strategy in times to come. There is reasonable success with about 60% reduction in exophthalmos and diplopia, about 80 to 90% reduced activity with this protocol. And of course, biologicals are knocking on the door. So thyroid eye disease is like a house on fire, and you have to douse the fire with all this that I have described before we rebuild the house. Thank you so much.
Thank you, Dr. Santosh. That's an excellent presentation. There's a question to you, like what is the maximum dose of immunomodulation and any recurrence following your combo therapy of IVMP and azathioprine?
Yeah, there is a recurrence in about 20 to 30% of patients over a period of time, 3 years period, there is a recurrence. But recurrence can be mild to severe, and recurrence generally depends on quality of, on the lifestyle of the patient. If the patient were to start smoking, there can be recurrence. If the patient has a suboptimal thyroid control, or if the control has been very haphazard with peaks of hyperthyroidism and trough of hypothyroidism, then they can recur. Or if the patient has undergone a radioiodine therapy, then the patient can recur. So with all these put together, I think medical management is the key to success in surgery. About the dose for azathioprine, we use 50 milligram twice a day. That is the standard dose to begin with. Mycophenolate is used in the dose of 500 milligram twice a day. That is the standard dose to begin with. Then you can taper the dose depending on the response and the side effects.
Thank you, Dr. Santosh. Dr. Grover, sir. Dr.
Yes.
Grover, any inputs from you, sir?
I had a couple of questions for Santosh.
Yes.
Excellent talk, excellent clarity, Santosh. 2 questions. You've given a dose up, say about 6 milligrams or 7.5 grams of IV methylprednisolone, and patient has a recurrence a few months down the line. Would you now still be constrained by the thought of not exceeding 8 grams, or would you now give another fresh dose? Is there any evidence that methylprednisolone lasts in the body to cause a toxicity with the previous dosage, or would you think you're starting afresh? That's one. The second question I had was, how do you choose between your immunosuppressants? How would you choose whether you're using methotrexate or whether you're using mycophenolate or azathioprine? How do you decide between them?
Well, young individuals, mycophenolate is the safest drug. For patients a little older, our mycophenolate is slightly more expensive than azathioprine is the next bet. Methotrexate I generally don't use, but it is preferred by endocrinologists. So I would either use azathioprine or mycophenolate more.
What about the steroids, IV?
Steroids, my cutoff is 8 grams. And beyond 8 grams, at least in the literature, there is a high rate of side effect, including hepatotoxicity and...
yeah, that's the thought you would have. But does that thought persist if you have to repeat, say, 6 months down the line?
Seems so, sir. Cumulative is total dose in their lifetime. So there is also an issue of aseptic necrosis of the head of femur. So there are a lot of issues with intravenous methylprednisolone when it exceeds the dose. So 4 gram is the safest bet. 4.5 gram is fine. 7.5, 8 gram is somewhat more dangerous. But yes, beyond 8, I would very hesitant. I would be very hesitant.
Okay. There is a school of thought who feel that after some time, then you do not have any residual effects of the previous IV methylprednisolone and you can start afresh. I would like to know whether any of the other panelists has an opinion which matches that.
Jeff may have an opinion. He has seen it all.
Sorry, I was concentrating on another thing at the time. Sorry, but probably
whether you've given a dose which is about 8 grams of IV methylprednisolone, the patient develops a recurrence 6 months down the line.
No. If reactivation, in most cases, you find it's either heavy smokers or have got their thyroid has gone out of control, is what I've found. And once you get that thyroid controlled, they generally quieten down. I may give them a little more steroid, but I get a bit edgy because of the reports.
Yeah.
Thank you, Dr. Jeff. As we are already running a bit late, I think we'll go to the next speaker, please. And here I take the opportunity to introduce Dr. Raymond Douglas. Dr. Douglas is a board-certified aesthetic and reconstructive oculoplastic surgeon in Beverly Hills, California. He completed his fellowship in orbital facial plastic and reconstructive surgery at the University of California, UCLA Stein Eye Institute. He is also the chief medical officer of Flowmetric Inc., a medical device company that develops aging and inflammation testing. He is an internationally recognized educator, clinical researcher, author, and a renowned expert in the treatment of eye diseases related to thyroid disease. So today he'll be talking in a newer trend in the management of thyroid eye disease, the landmark breakthrough, the teprotumumab. So thank you, Dr. Request Dr. Douglas to please go ahead with your presentation.
Thank you very much. It is can you see my screen?
Not yet.
Yeah, okay. Okay, should yes. Great. The technology is always the part, but so it's my pleasure to be presenting today. I'm only a little disappointed that it's not in person because it is one of the the best places to come and to enjoy and see old friends. So I do enjoy seeing everyone, and certainly hope we can do this in person in the near future. Today, I'm going to be talking about teprotumumab, and I was asked to speak about the biologic mechanism and some about the clinical effect. And I understand that teprotumumab is not available outside the US. But what I really want to speak about is the biologic mechanism that I think is going to be so important in the future, because undoubtedly there's going to be other agents that will be introduced that take part in the same or quite similar mechanism, and that I'm very certain that this will be available much more widespread, whether it's teprotumumab or something else in the future. So I think understanding the biologic mechanism and the differences will be quite key. Sorry. So I am a consultant for thyroid eye disease therapies for both Horizon, Immunovant, which makes a different compound, and Viridian, which is also into the IGF-1 receptor, idea as far as therapies. So we know that, and part of this is stepping back and thinking about what are the underlying aspects, the universal theories of thyroid eye disease. Well, we've heard a lot about inflammation, tissue expansion, and remodeling in the orbit. And in general, that's kind of what we're dealing with, whether it's some patients experiencing a predominance of one or more of these aspects. And we know that this increase in remodeling, and precisely an increase in cellular proliferation and extracellular matrix accumulation, in addition to inflammation, is what leads to both the short and the long-term consequences in this disease. So I want to very simply break the disease into acute and chronic thyroid eye disease, because I think that there are overlapping pathophysiologic mechanisms here. And I think that one of the things we have to do is think about the immune system, but also think about the target tissue, which is the fibroblasts. And, as I talk about acute or active disease, it'll be, it's typically 2 years or less. It's progressive, as Peter mentioned, changing symptomatology, whether that be proptosis, double vision, inflammatory signs and symptoms, et cetera, a higher clinical activity score. No surprises to the group here. And then chronic or stable disease, again, just as you've heard it, is typically longer than 2 years, stable, non-changing proptosis and double vision. And we've often thought of the ideal therapy of introducing it early in this process and then being relatively unable to alter the disease later on. And that does take into account many assumptions of the pathophysiology by saying that. One is that we have to think that, well, early in the disease, there is this inflammatory process that we see as clinicians and signs and symptoms, and then that fades. But remember that during the chronic process, there's also a tremendous amount of increased metabolic activity, almost a new set point by the orbital and periorbital fibroblasts that now increase extracellular matrix deposition, and they do so in waves of different extracellular matrix deposition. We've looked at the transcriptomic analysis and the gene usage of every gene that's used by the orbital fibroblast and found an incredible array that chronic, just because it doesn't look like it's changing, is very actively turning these processes over, usually in every few days. So let's start to break this down even further into short-term inflammation, which, I think, the redness, chemosis, the typical inflammatory signs. And for most of us, I think that we have agents that will be able to help with those. We have anti-inflammatory agents, and many you've already just heard that can do quite well. What we've not been able to successfully deal with are the long-term consequences so easily: the strabismus, double vision, proptosis, the tissue expansion that's typically so characteristic of this disease. And so, one of the things that we've learned is that the anti-inflammatory processes, and maybe we're just not picking the right timing, et cetera, but there's been no placebo-controlled trials demonstrating an effect of these agents, of reversing the underlying alterations of the orbital tissue, such as proptosis and strabismus. We did a huge meta-analysis of steroids and found that the placebo-controlled trials, all by under the go-go guise, were about less than 2 millimeters. They were usually about 0.7 millimeter reduction of proptosis, and with substantial side effects. So we do a very good job with the inflammatory process, but not so much with the long-term process. And that led to several years ago molecular targeting of the antigen. So instead of just targeting the immune system, can we target the antigen or the subject of the immune system assault? And what I'm going to put forward to you for mechanism, I think, is what many of these therapies will be built upon in the future. And that is thinking about what is the target of the immune system and how does that target or the activation of that target affect both the short-term and the long-term manifestations of the disease. So fundamentally, the one thing that we've learned in the last 15 years in the laboratory is that the insulin-like growth factor 1 receptor is overexpressed on Graves' disease fibroblasts and immune cells. You take identical twins, as we did from Denmark, person who has the disease has IGF-1R overexpressed, person who doesn't does not. And consistently, of the one thing that's been the most consistent in 15 years is there are always overexpression of the IGF-1 receptor. And that signaling through that receptor mimics the pathologic findings that we see in this disease: extracellular matrix turnover, production of IL-6 and production of inflammatory molecules, activation of T cells. Everything that we've devised to inhibit also is downstream from this receptor. And that there appears to be antibodies to these receptors in Graves' disease patients and to the construct with TSH, the TSH receptor, which I'll speak about also. So the IGF-1 receptor, again, being the hallmark of Graves' disease, this is just overexpressed on T cells and as we're showing here in Journal of Immunology now, dating myself quite a bit, but also in B cells, monocytes, orbital fibroblasts, every cell tissue that we could find in the periorbital environment, and the immune system appears to overexpress the IGF-1 receptor. So that, leads us to believe that potentially this receptor is involved. And not only is it overexpressed, but there's not overexpressed in other autoimmune diseases. Here shown in Graves' disease and CD4 T cells, where in Graves' T cells, this is overexpressed, not so much in other autoimmune diseases. So it highlights the potential central role of the IGF-1 receptor. This became much more apparent a little bit later on when we found that the IGF-1 receptor actually commingles. It actually forms a molecular bond with the TSH receptor. On thyroid cells, though the TSH receptor far exceeds the IGF-1R, but on orbital fibroblasts, the IGF-1 receptor is in quite abundance, where the TSH receptor is actually quite small. But when they exist as a pair. They are receptors that bind together and are linked together, such that when you activate one, or block one, you actually block the activation of the other receptor. So for example, we were able to show that if you block the IGF-1 receptor, you not only block the downstream signaling of the IGF-1 receptor that leads to hyaline production and extracellular matrix production, you also block the TSH receptor from producing IL-6 and from other inflammatory cytokines, all in orbital fibroblasts. So a very unique set of scenarios where these two receptors, seemingly unrelated, but are actually on the surface of the cells of interest in this particular disease, leading us to really think about, the mechanism here. So we know that in beginning to think through this over, pretty much a couple of decades, and looking and building the preponderance of evidence that if we could block this signaling of the IGF-1 receptor, maybe that would then lead to stopping or discontinuation of the IL-6 production, of hyaline production, etc. So teprotumumab is a mechanism of action of one particular medication. You're going to see more. And there's going to be other ones that also have targeted binding to the IGF-1 receptor that will likely inhibit the IGF-1 TSHR signaling complex. And the reason why there are so many medicines made like this, by the way, just as a side, is that the overexpression of the IGF-1R was also seen in sarcoma many years ago, and also somewhat in breast cancer cells in some subtypes. And so it became a huge interest for some companies to develop anti-IGF-1 receptor blocking antibodies. It didn't do so well in the sarcoma field, and in breast cancer, it didn't deem to be worthy of following up. But there are lots of these molecules on the shelves, and I'm sure people waiting to come into this field to actually produce these. Anyway, we know the targeted binding likely of this IGF-1 receptor or of this IGFR TSHR signaling complex will likely lead to fibroblast involution, decreased proliferation, decreased hyaline production, decreased cytokine production. We've shown all that in the lab. And so that was the mechanism of action that led to at least the idea that, well, maybe this will work in a clinical trial and prevent the excessive growth in hyaline behind the eye. So here's a little bit, again, now returning, putting that mechanism of action together. And what I want you to draw a little bit of attention to is looking at the acute thyroid eye disease or active thyroid eye disease. It depends on the terminology, but I'm not trying to split hairs. The T cells and B cells are activated in part due to the orbital fibroblasts being at the center here and producing inflammatory cytokines. We know that the orbital fibroblasts also have CD40 ligand. They have a lot of ligands that activate the T and B cells. We know that stimulation of the IGF-1 receptor TSHR complex is likely central to this whole process. Still unclear exactly how and why, frankly, because I think it's a little more complicated than we think it is, but that's a different story for a different day. But leads to activated T cells and then The downstream is that we've shown in many publications increased hyaluronan synthesis, glycosamine, glycan, increased differentiation to adipocytes, myofibroblasts, inflammatory cytokines, everything that we know as far as tissue expansion and inflammation. Now, as a setup for later, what happens in chronic thyroid eye disease? Well, we know that the tissue still overexpresses the IGF-1 receptor. There's still, a process, presumably, that is relatively unchanged, but we do not see continued activation of B and T cells, etc. As in typical immune responses, you have an immune response, and then that immune response begins to cycle itself down by very specific mechanisms. But what we do know is that the orbital fibroblast continues to be active in producing hyaluronan, glycosamine glycans, and very other extraocular or extracellular matrix molecules in very high rates. So it's almost like it has a new metabolic set point. They're almost cancer-like orbital fibroblasts that now have a new set point. And frankly, it's the only way that you can really think about and explain an involutionary process of some of the data that we'll present later, that you're actually interfering with the metabolism of the orbital fibroblasts in addition to the immune response with IGF-1 inhibition. So coming back to testing this and the clinical effects, let's go through some clinical data. Well, we know that teprotumumab in the treatment of the eye disease, this was published in the New England Journal. There were 2 phase 2, phase 3 trials that we headed, and looking at primarily active thyroid eye disease. The reason why we chose active thyroid eye disease is that if we took a poll here, everyone would agree, let's do active disease, not late stage disease, and we're going to do teprotumumab versus placebo, because there's been very few placebo controlled trials, and it appears worthy that if we're going to have a natural history of disease that improves, we should have placebo. The most important thing, was the primary endpoint, and that was an improvement in the disease outcome, meaning at least 2 millimeters improvement in proptosis, plus various degrees of improvement in double vision. Because we have so many great treatments for inflammation and for reduction of clinical activity score, plus the FDA didn't want to hear anything about reduction of clinical activity score. They only wanted to know about improvement of long-term disease and proptosis. So the summary of results pretty much of both trials were that the primary outcome of proptosis responders, meaning the percent of patients with at least 2 millimeters reduction in proptosis from baseline, was significantly greater with teprotumumab than placebo. And and I'll show you the data, and it was quite dramatic. And then all secondary endpoints were also met, meaning that the clinical activity score went down in a preponderance of patients to 0 or 1 by the completion of treatment. The patients improved in diplopia, and the mean change in proptosis was also very different. And also the quality of life scores were different. The FDA really only wanted proptosis, so that's why these were the secondary endpoints. This is a placebo patient pre-treatment, week 24. You can see that there's probably a little worsening of this disease process, certainly not improving. Here's a patient who had pre-treatment versus post-treatment and about a 5 millimeter improvement. These are patients who were published. And at week 24, an improvement of the proptosis. And I'm sure most people are familiar with this. So a dramatic improvement in the proptosis. And we also measured volumetric muscle expansion, showing that both the muscle size, the volume of the extraocular muscles, and of the fat both decreased during this time period. Here's the clinical score, activity score reductions. You can see in the gray that the natural history is that the clinical activity score improves. Here, within 24 weeks of patients who are diagnosed 9 months or less, by at least 2 points, an improvement much more with teprotumumab. And 60% of patients treated with teprotumumab had absent clinical activity scores of 0 or 1 by the end of the study. They all had to have 4 or greater to be enrolled. Proptosis response, a reduction of greater than 2 millimeters. You can see the response rate. seems to plateau, possibly due to the patients are having improvement. Once you get to about 80%, it begins to plateau at week 18 to 24. This is based upon an intent to treat analysis. So if a patient missed an appointment, if they missed the week 24 because they couldn't make it in, they were considered a non-responder. So this is a very tight analysis. And the number to treat, meaning an intent to treat analysis, which means how many patients do you have to treat to get a response, was an amazing 1.3. It's almost unheard of, for some of the, medications that it's so low, because normally you have to treat a lot more patients to actually get a response. Proptosis reduction tended to be right around a little over 3 millimeters. It was about 0.5 millimeter in the placebo. And then at week 24, you could see about 3.3 millimeters improvement in the New England Journal. And not overall surprising, if you have reduction of proptosis, we've now demonstrated extraocular muscle reduction. We've published upon this separately. Both it appears to be an improvement of the inflammation in the orbit, but also the size of both the fat and the muscle compartments. The diplopia response was measured via Gorman because it was a multi-center international trial, and there's a dramatic improvement in diplopia. Of at least 1 grade, then those were considered responders at that point in time. Also, approximately over 50% of patients had complete resolution of their diplopia. So we can see that effects at 24 weeks certainly very good. The overall quality improvements, again, both facial appearance and vision, both very good. The safety profile appears to be very good. Even in the real world, safety profile treated quite a number of patients, appears to be similar, and we can talk more about that, but it appears to be very reasonable. There are a couple that I think certainly for inflammatory bowel disease, for diabetes, have to be very careful. This is still a biologic. Even though it has a good safety profile, people still have to be careful, and what I find is you just have to be very careful in your use, not indiscriminate. So what is the durability of response? And this was very recently accepted to the Lancet. I'll give you a sneak preview of this. And it appears that the durability, meaning the proptosis responders, diplopia responders, I told you that they were about 83 or in the 80%. This is from both trials. After 60 weeks after initiation of therapy, meaning about 40 weeks off of treatment, they're still 87 and 88%. For proptosis responders. So, it appears to be quite a durable effect in most patients. And again, this is still an intent to treat analysis. So, we're still following patients for this period of time. Diplopia responders also appears to be quite durable. With 66% at week 7, it actually even went a little better, maybe even with the natural history of an improvement over time, was up to 78% of diplopia responders. The complete analysis, as I said, will be out very soon in that journal. So how does teprotumumab also reverse chronic thyroid eye disease? And I don't know if Jeff Rose remembers, but I bet him a beer about 5 years ago that this would be possible. But how is it possible? How can you actually reverse disease that's been going on for longer than 3 years, has low clinical activity score? Everyone in this room would call those patients stable. Well, it comes back to that same pathophysiological understanding of the overexpression of the IGF-1 receptor. We demonstrated this recently in a non-inflammatory study, but the single most important thing is that the IGF-1 receptor maintains overexpression in inflammatory, non-inflammatory, and chronic compared to controls. And it appears to inhibit the metabolic turnover of extracellular matrix molecules. And it appears to reverse chronic thyroid eye disease. Again, just coming back to that diagram, just so that you can see that turnover. We see about a greater than 3 millimeter reduction in proptosis in patients who are chronic and who have chronic thyroid eye disease over the course of this treatment. We have about 30 of these patients, so we've had from a multi-center analysis. This is just an example of a patient on the left with it, with view and then on attempted up gaze. They proves double vision. This patient had the disease for over 6 years, absolutely did not want surgery. She had it and it made an improvement. We're also looking at and will show the improvement in the volumetric scans on patients with chronic disease. Again, I think this efficacy compares reasonably to decompression surgery. We seem to uniformly be getting over about 3 millimeters in active, chronic, etc. The conclusion of it is that we really have to sit back, and this is our first entree into the biologic world of a disease-specific biology for thyroid eye disease. And in dealing with the mechanism, there's a lot of things we don't know, but what we do know is overexpression of the IGF-1R is a hallmark, and the signaling cascade of this receptor complex appears to be critical. And chronic is not so quiet. Chronic, there's a lot going on underneath the surface, especially as far as extracellular matrix deposition, and we'll have a lot more on transcriptomic analysis to determine that. But thank you very much for allowing me to speak, and really look forward to the other presenters.
Thank you, Dr. Douglas, for the very insightful talk. Can we have a question from our President OPI, Dr. Usha, please? And as we are running out of time, we'll restrict to one question after each talk, and then at the end, we'll have the panel discussion. Dr. Usha Kim?
Yeah, the only thing is it's really a very difficult and very challenging disease condition, which all of us are struggling a lot. And we do see a lot of patients in this part of the country too. So all these talks are very useful. And I think it has to be customized to the patients. And it's very difficult to generalize and give the verdict. So it's been very useful this far. So looking forward to the rest of the talks as well.
Thank you, Usha, very much. So we'll now go to the next talk, and I request Dr. Mukesh to please introduce Dr. Raghavan Sampath.
Thank you. So Dr. Sampath Raghavan is a consultant lid, lacrimal and orbit surgeon, and also honorary, also associate professor at University Hospital of Leicester, UK. He has completed his fellowship at Manchester and Moorfield, and he has trained many oculoplasty, more than 30 oculoplastic surgeons, and won various awards at national and international meetings. We all know him, and he's a great teacher, let me say this. I'll also here request all the speakers to please restrict to the time, because we have got many more talks which are left, and this is a long session. Thank you. So I welcome Dr. Sampath.
Sorry, it's coming on a different, okay. Can you see the screen, team?
Yes, yes.
Thank you very much to Santosh and the AIOS team for having me on in this session after an excellent talk. So far, mine is going to be more down to earth and at the coal face. What do you do when a patient presents? So thyroid eye disease is an autoimmune disease. So before you consider decompression, you need to control all the trigger factors. It's extremely important to get the thyroid functions under control. One of the big triggers in this part of the world is smoking. Try to control that. Associated medical conditions. Obviously, we can't control too much on sudden severe stress like bereavement, loss of job, divorce, etc. We are definitely seeing those as factors in the eye disease. Would you consider decompression in the active disease? Usually not. Only if it's really serious, as described by the various grades, a grading of systems, and imminent risk to vision. If there is evidence of worsening of disease in spite of active management of everything that has been said so far, and obviously the other categories without serious and imminent risk to vision, you'll never consider a surgical intervention. In the active disease, if the optic nerve signs are getting worse in spite of active disease, then you need to you definitely need to consider decompression surgery. And the red flags of compressive optic neuropathy: red desaturation, reduced vision, contrast, optic disc. This is usually much later in the disease. And visual field, which we always do in every visit. So if there are visual field defects which are getting worse in spite of treatment, then you would consider going for decompression if necessary. Exposure keratopathy, red flags are suboptimal tear film, poor Bell's phenomenon because of associated motility issues. There are very rarely patients with corneal graft who develop thyroid-related disease. Neurotrophic keratopathy and poor blink reflex, which I'll show you a case where this really led to quite severe issues with the patient's vision. Hydraulic thyroid eye disease or orbital pressure thyroid-related disease give rise to headaches, orbital ache, eyelid edema. They may give some signs of activity, but they're actually not activity. But hydrostatic signs, well described by David Verity and Jeff Rose's paper. And looking at radiological features, orbital apical crowding, and looking at orbital fat prolapse. And we all know that 75% of the thyroid eye disease is usually due to muscle enlargement, and 25% is due to fat cavity enlargement. And you can check the muscle index if it's greater than 70%. These are the ones which cause optic nerve compression. What are the high-risk groups where you need to closely watch them and interfere surgically if necessary? Male definitely if they get eye disease at an older age group, they're definitely at higher risk of things going wrong with their vision. Smokers, diabetes adds a huge problem to their management with steroids and obviously radiotherapy. And if it's rapid progression at onset in spite of all the treatment provided. And the older patient onset is the ones which we worry a lot more. They don't get much proptosis, but their eye disease is more in the posterior orbit with muscle enlargement and crowding of the orbital apex. And any concomitant optic nerve pathology, some of these patients could be vasculopaths with ischemic optic neuropathy, etc. Looking at the non-active disease where you may consider decompression as an option is cosmetic decompression. And when the activity is all died down and the patient has motility issues with proptosis, I don't think many squint surgeons would operate on an eye which is proptose. So they would like you to settle the eyeball first before they'll consider doing squint surgery. And the pseudo activity of hydraulic, which we looked into, and sometimes you may need to interfere for the uncontrolled intraocular pressure. And even if there is no activity, no hydraulic pressure, some of the patients with expanded orbits do have quite significant chronic pain, which are not controlled by any other means. There are no signs of activity, and decompression may be the only option. But there is something called white eye disease or non-active disease with optic nerve compression. We all have come across this in practices. So these are the patients, which is a well-recognized condition. Again, goes to show that the individual patient, the Rundle curve, the scoring systems may all not be that appropriate for the individual patient sitting in front of you. So in this particular situation, decompression may be the first line of management. Preoperative workup, if needed, we as was discussed about reactivation of the eye disease, we will always give intravenous steroids perioperative, even if the eye is there is no activity. For a non-active proptosis, we will still do IV steroids and followed up with a long-term oral steroids for up to 4 to 6 weeks in any patient to have any surgery around the eye in a patient with thyroid eye disease. And we use quite a lot of tranexamic acid, which has definitely helped over the last 5 years when we first started using them. Before decompression decision, obviously, we have heard various talks on what all you need to do before you consider taking the patient for surgery. And we have heard some wonderful drugs and etc. But my talk is basically all that has been done and the patient is sitting in front of you who has not responded. or is getting worse in front of your eyes. So decompression only after all the other options have been considered. Surgical environment for the decompression, well before the decompression, what would you do? Anticoagulants need to be controlled, as we all know, for any orbital surgery. And in our practice, we always get the anesthetic team, which we are familiar with. They get an arterial line, and the arterial pressure is maintained during surgery for good reason, because if you want to bleed, you want it during the procedure rather than afterwards. So we do not believe in hypotensive anesthetic for orbital surgery. And at the same time, because of the raised pressure in the orbit before and during the surgery, if you reduce the arterial pressure, there is a higher risk of these patients ending up with worse vision because of vascular problems during procedure. And we use tranexamic acid. We always have a familiar anesthetic team, and we are always available for immediate post-op intervention if necessary. Since tranexamic acid is not that well known in the oculoplastics world, or not widely used as it should be, this is the sort of dose they get at induction of anesthetic. And when we do a medial decompression through the endoscopically, we give an intranasal pack as well of tranexamic acid before the surgery. So this is the sort of solution we use along with Merocel tampon or with the neurosurgical patches. And before you consider, once you have decided all the medical treatment has been done, your immunologist has said, I've done everything I can, doc, here is the patient. And unfortunately in UK, we don't have access to teprotumumab. The cost currently quoted on the internet is about $200,000 to $300,000 for a year's supply. I can't see NHS approving it at the present time. So when these patients present to us, if you are going to consider decompression, a CT scan is essential. You want to know the level of cribriform plate, especially when you're doing a medial wall, and you want to know the status of the sinuses, and you want to know the status of the lateral wall anatomy. These are all necessary before you decide to go ahead with a decompression. Would you do fatty decompression or bony decompression? In our practice, which is a tertiary referral practice, is mainly patients who come to us after having had initial treatment elsewhere, and majority of them involve muscle enlargement. A quarter of them are due to fat hypertrophy. And an important test is retropulsion. Even if they are inactive disease, if you retropulse and the eyeball bounces well within the orbit, those patients are going to do well with your decompression. If the retropulsion shows the orbit is very tight and fibrotic, these patients are not going to do well with orbital decompression. And you need to decide before you take the patient to theater what sort of decompression you want to do. All the medical treatment has been done. All the trigger factors have been sorted. Teprotumumab is not available. How do you correct this patient? In our practice, we have access to all the other drugs other than teprotumumab. So they get mycophenolate, azathioprine. We don't use methotrexate. Rituximab, unfortunately, our experience hasn't been that great. Cyclosporin, our experience hasn't been that great. So we have gone back to azathioprine and mycophenolate. So you want to decide number of walls. Retropulsion, I already mentioned. Is there optic nerve compression? And the books describe 3 to 4 millimeter per wall decompression. Unfortunately, it doesn't really work in the real world. Retropulsion, if it is soft, they are going to do well. If it's hard, you will need to do more than necessary. And again, you need to decide it's one wall, 2 wall, 3 walls, with or without lateral wall advancement. So we'll go through some cases to give a feel for what's going on. Here is a patient who wasn't thought to have thyroid eye disease, but he was picked up with reduced visual fields. And the referring team decided the visual fields could be due to something else because he didn't have proptosis or an obvious eyelid retraction. Though if you look carefully in the left, maybe there is. So they had an MRI scan of the head and the orbit, and you can see huge muscles in the back pressing on the optic nerve with significant visual field loss, but hardly any proptosis. And you wouldn't say this is severe disease on any scoring system looking at it unless you do the visual fields and vision assessment. So again, the scoring system, grading system is useful for progress one way or the other, but not so useful for the individual patient sitting in front of you. Here is another patient, again treated with IV methylprednisolone, and you can see that it has improved, but not completely. So these are the sort of crowding of the orbital apex, with some of them with very little proptosis. Here is a patient who's had medical treatment, IV methylprednisolone and oral steroids, still has significant proptosis and what looks like an active disease, and she had quite tight orbits. Again, she underwent a decompression on both sides, and you can see not only has the proptosis got better, but the activity is also completely gone. The eye is white and clear.
Dr. Sampath, sorry to interrupt. I've got 2 minutes more.
Right. Okay. I will. Okay. This is another patient with proptosis with mild activity, and again, decompression has completely finished off his activity and is a very happy chappy. Here is a patient with very severe proptosis, needed decompression. There is no way this patient is going to get better with any medical treatment. Here's an interesting patient which I missed, the blink reflex. So she came to us with very tight orbits, diagnosed thyroid eye disease, very little proptosis, upper lid retraction, gave her IV methylprednisolone, and then she developed a corneal ulcer on the right, and then the penny dropped. The corneal surgeons took over and nothing worked, so we had to do a tarsorrhaphy on the right, and fearing the same could happen in the left, I did a small tarsorrhaphy because she didn't have much proptosis, or she was not responding to drugs, and with this her blink reflex got better, her cornea got better, and she didn't want the tarsorrhaphy to be open. She was quite happy to be left alone like this. With extreme proptosis, there is no way you can't get this eyeball back by simply planning a simple decompression. Here, you need to have a better plan before the surgery. Here, we had to advance the lateral wall really forward. That's the original lateral wall. That's the new lateral wall. That's the lacrimal gland. In extreme proptosis, you have to do this in addition and plan for this. Here's an interesting patient who came to us with significant proptosis on both sides, burnt out myasthenia gravis, no Bell's phenomenon, no ocular movements, completely globes out of the orbit, and huge enlargement of the fat cavities, not an active disease, elderly lady. We did a bilateral decompression, took the lateral wall forward, and since she did not have any Bell's phenomenon, I had to do a tarsorrhaphy, which is accepting defeat as far as an oculoplastic surgeon is concerned. The next patient, what looks like glaucoma, she was seen by the glaucoma team for visual field defect and did not have any proptosis. And this was the defect. And at this point, they referred her across after the scan because it showed some problems in the orbit. And at this point, she didn't have thyroid function abnormality, but had enough elevation of thyroid antibody levels. So she has bilateral medial rectus enlargement with optic nerve compression, but not an active disease, but severe in any classification with significant visual field loss. She had a small medial wall decompression, transcaruncular, and this is a visual field post-op. So individual patient sitting in front of you does not follow the various patterns. Since I've been given a set time, here very advanced diseases which are not going to respond well to medical treatment. Here is a patient with a significant proptosis and conjunctival edema, chemosis with keratinization. Here is a patient who I remember well, was tertiary referral, had a tarsorrhaphy done elsewhere, poor blink reflex, completely proptose globes with corneal abscess. We gave him IV methylprednisolone, took him straight to theater, did decompression on the right and then later on the left. And the corneal team managed his cornea beautifully, and you can see how well he has done. So this sort of patient, you have to plan a decompression. He's not going to get better. Just one more slide on cyclosporin. And we burnt our fingers with cyclosporin. We don't use it anymore. Here is a typical patient who had every side effect you can think of from the steroids, from the cyclosporin, and eventually he settled with decompression. I will just go to conclusion.
I'm sorry, your talk is excellent, but because of
Right,
paucity of
okay,
time.
just conclude. in conclusion, orbital decompression is safe and effective as long as you have done everything that is needed to get to that stage. It has to be planned and surgical environment extremely well controlled. In our series, the reactivation was less than 2.5%. So if you plan your patient well, treat them adequately before, and have strict indications for decompression, and give them immunosuppression, even if they are non-active at the time of surgery, they do well. Thank you.
Thank you, Dr. Sampath, for the excellent talk, but we are sorry we had to run fast. Can I have a comment from Dr. Bhattaria, please? Professor Bhattaria? Sir, you're muted. Sir, can you unmute? Yes, sir.
Dr. Sampath has covered very nicely. The decision of orbital decompression should not be taken very lightly, because it is the end result, and many times what we find is the development of diplopia, which is very common in about 25% of cases. So I think Sampath has covered everything very, very nicely, and lateral wall decompression and the floor, these two walls are easy to decompress, and we should go for that. I feel like that.
Thank you, Dr. Bhattaria. Now I'd like to request Dr. Gunjan to introduce Dr. Robert Goldberg, please.
So it's my privilege today evening to introduce to you Dr. Robert Goldberg, sir, who heads the oculoplasty division at UCLA, Los Angeles. He is an internationally recognized surgeon, researcher, and teacher. Sir has more than 300 publications, which includes chapters and textbooks. Moreover, he is an editorial board member for several prominent ophthalmic and plastic surgery journals. So he is a section editor for American Academy of Ophthalmology online education. Today, sir will be talking about the best approach to orbital decompression. Over to you, sir, for the lecture.
I think Dr. Goldberg has sent his recorded talk. May I request Dr. Santosh to please play his talk?
I see him logged in, Kasturi.
Oh, he's there? Dr. Goldberg?
I can see him in the panel.
Okay. Dr. Goldberg, please, would you like to share your slides?
Do you have the recorded talk? It might be easier.
Okay, sir. I think it. Can you please go ahead?
Hi, Bob.
Thanks very much. Pallavi Singh, our incoming fellow, and I would like to present the details.
Are you able to see the screen?
Orbital decompression.
No, not yet.
I'm sorry I can't be in India. Delhi is a beautiful city. I've visited there, and I like the country very much. Perhaps next year we'll all be doing live meetings again, and I look forward to seeing you in person. And I want to thank the course organizers, and particularly Santosh, for inviting me to this excellent session. All the material listed.
Oh my. Then maybe we can go to the next talk, and by that time I'll sort it out.
The next talk we have by Dr. Michael Kazeem. Can I ask Dr. Mukesh, please, to introduce Dr. Michael?
Yeah, sure. So, Dr. Michael is a clinical professor of ophthalmology at Harkness Eye Institute, Columbia University. He is recognized in the field of orbital diseases, orbital tumors, and thyroid disease. He is a member of various societies and also a founding member and first president of International Thyroid Eye Disease. Today, he will be speaking on radiotherapy still used in thyroid eye disease, and if so, when. Dr. Michael, please.
Right. Thank you very much. Can you all see the screen?
Yeah. Yes, sir.
We're good. Great. Santosh, thank you so much for organizing this. And I echo Bob's remarks that hopefully next year we can all meet in person to enjoy each other's company. So after we've heard all these wonderful lectures, the question does arise as to where we go with medical treatment in the future. I have no financial disclosures. The slide here has been demonstrated before. There are all sorts of available targets now for treatment. And consequently, we have the ability to, with steroids, suppress the entire inflammatory response. NSAIDs are a little bit more specific, targeting COX-2. TNF alphas go after the PGE2 targets. We have tocilizumab with IL-6. Rituxan B-cell depletion overall is a very effective drug, not only for thyroid eye disease in our experience, but also for other autoimmune diseases. The Tepro we've heard a lot about today with its IGF-1 receptor effect. But I'm being asked to talk about radiotherapy. And radiotherapy has some very interesting effects. While it does not affect particularly the activated lymphocytes, it does prevent those lymphocytes from secreting the proteins that are participating in the inflammatory matrix. And perhaps even more importantly, they cause terminal differentiation of the progenitor fibroblasts in the orbit. And since we've already learned about how important the fibroblasts are within the orbit, these pluripotential fibroblasts, if rendered routine and uninteresting, could very well be the most important effect of radiotherapy. Secondly, what factors do I think are important in evaluating the effectiveness of thyroid eye disease treatment? Well, I think you need to measure the modulation of the disease, the degree to which it can suppress activity or progression. That's what normally is measured in terms of CAS, in terms of proptosis reduction, motility changes. But more importantly, to my mind, does it modify the disease? Can it durably suspend the active phase? Does it reverse the clinical features? And probably as a surgeon, does it reduce the need for surgical intervention? And then, of course, we need to take into account safety and cost. We see in this graph, and just to point out that modulation takes the Rundle's curve down the y-axis, but modification, the more important point, takes the curve to the left on the x-axis, decreasing the duration of activity and therefore the irreversible effects of the disease. How can you identify disease modification? Well, the interruption of the anticipated disease progression, again, over a course of about a year to a year and a half of activity. The prevention of disease relapse with the withdrawal of the agent, and the need, again, for surgical rehabilitation. So let's look at a couple of treatments that we're very familiar with. Well, to begin with, the most commonly used corticosteroids, and more recently among the intravenous route. Here, a UGOGO trial in 2012 demonstrated in 3 different subgroups that CAS was reduced, not surprisingly, more drug, lower CAS. But there was a full 1/3 reoccurrence of thyroid eye disease, after withdrawal of the drug. In the Moritz trial on compressive optic neuropathy, intravenous steroids were used to a dose of 4 grams, and 60% of these patients still required decompression surgery. So that's not disease modification. Tepezza, we've seen, produces a reduction in CAS reliably, somewhere in the order of 3.5, a proptosis reduction of about 3 millimeters. But in the phase 2 trials, they demonstrated a relapse rate in CAS of about 30% and a proptosis relapse of about 40%. And overall, there was no difference in the number of surgeries required for the patients that were treated versus the placebo group. Rituximab has demonstrated in one very interesting study compared to IV steroids that the CAS response is better, 100% in the Rituxan group versus 70% in the IV steroid group. But most importantly, they had a reactivation rate of 0% in the Rituxan group, 30% again in the IV steroid group, recapitulating prior studies, and a lower rate of surgery. So that's disease modification. When you look at the effects of radiotherapy now, this has been around since, with the current protocol, about 1973. 1992, Chuck Leone showed that patients who were steroid dependent came off steroids if you gave them radiotherapy. In 2004, Mark Prummel showed that radiotherapy, however used in mild cases, didn't change much. Similarly, the Mayo Clinic showed that late stage disease, averaging a year and a half, also failed to show benefit. But in the Moritz prospective trial, radiotherapy versus sham treatment, there was a 60% improvement in the field of binocular vision and a 25% reduction in the need for strabismus surgery. Peter Doleman spoke about his trial in which he looked at patients who were treated with steroids alone versus steroids plus radiotherapy. The steroid alone group had a 17% development of compressive optic neuropathy. None of the patients in the steroid plus radiotherapy group developed compressive optic neuropathy. Again, a modification in the way that the disease progresses, a shortening of the course. In our study that we published in 2017, we looked at 133 patients who were treated with a combination of steroids and radiotherapy. 104 of them were for compressive optic neuropathy. The remainder were for rapidly progressive disease or steroid dependence. These are patients, now I will speak about specifically with regard to compressive optic neuropathy, who were steroid responsive. None of them had a vasculitis or vasculopaths. They were trialed for 2 weeks with steroids. If there was improvement, they received radiotherapy, 2,000 centigrade, and then they had a taper for approximately 12 weeks to a cumulative average dose of what is the equal of 2.5 milligrams of methylprednisolone on the low end of total dose. And in these patients, a full 93% of them had a durable response in optic neuropathy, i.e., relapse occurred in only 6% of patients. And overall, only 13% of these patients went on to a stable phase elective decompression. So if you look at the data, 85% of these patients were spared a decompression surgery either on an elective or an acute basis. Only 6% underwent, again, acute phase decompressions for failed or relapsed treatment. What's the safety profile? Well, this has now been around in the current iteration for about 50 years. There has been no demonstrated increased tumorigenesis. There's a 5% chance of cataract, and retinopathy is avoided if you do not treat people with poorly controlled hypertension, insulin-dependent diabetes, or some type of systemic vasculitis. That compares favorably for two more durable uses of steroids, which we're all familiar with after 40 to 50 years of treatment. Rituxan, unfortunately, is associated with a 1 in 10,000 rate of death due to unreleased PML. And Tepezza is relatively new, so we're beginning to learn more and more about the side effects, one of which is troubling to many of us, is the hearing loss, which is now becoming more and more well characterized. What about the costs? Well, steroids are cheap. $100 for a full course of oral, $4,000 for intravenous. Decompression surgery is roughly $18,000. Again, these are all US dollar figures for Medicare reimbursement. Radiotherapy is less than half of that at $8,000. Rituxan is between $5,000 and $20,000, depending on the protocol you use. And as mentioned earlier, Tepezza is now approaching some $400,000 all costs in. So overall, I think that the data has demonstrated in a number of studies that radiotherapy shifts the activity score of the disease to the left, and that this occurs in a period of about 3 months after instituting the radiotherapy. And consequently, the severity of the disease is depressed, the irreversible components of the disease are limited, and thereby you're reducing the need for surgery, and you are changing the paradigm of treatment from surgery first to medical therapy first, sparing all but those patients who are the few that require urgent decompressions, the 6% or so in our study from an acute phase decompression. The remainder undergo stable phase decompressions on an elective basis, a far fewer number, therefore far fewer incidents of the need for rehabilitative strabismus surgery, and converting these types of patients to a quieter look. So where does radiotherapy live? It is not indicated, bear in mind, not indicated for mild disease. It has no added benefit. Late phase disease, it has no added benefit. Stable phase disease, steroid responders, vasculoplasty. And late phase disease, I should just take a moment to refine that concept. Stable phase, I think we all understand to some degree. Late phase are those patients who are close to the end of their active phase. So as I said, we all know that this disease lasts about a year to a year and a half. So if a patient shows up at month 3, 6, they're clearly indicated, 9 even. But if you see a patient at month 12, one has to begin to consider alternate measures. What is it indicated for? Acute phase disease, steroid responsive, compressive optic neuropathy. Again, like this gentleman on the right, and it was mentioned in the last talk. If you do not have a steroid responsive effect, this will not help. And this patient went on to acute phase decompression. And it can be helpful, although we don't see as many patients any longer. I no longer am using steroids ad infinitum, but if you have a patient who is steroid dependent, that's a helpful way to get them off steroids. And as Peter Doleman alluded to, these rapidly progressive orbitopathies that are congestive and are beginning to show eccentric diplopia can be managed well with a combination of steroids and radiation because it stops their disease, it reverses the congestion, and in some ways improves their motility, avoiding again the need for decompression and for strabismus surgery. Thank you for including me in this wonderful seminar.
Thank you, Dr. Michael. Dr. Santosh, are you ready with the video? Can't hear.
You know something?
Yes, now we can hear the voice.
No, that was me talking, Custer. Okay. You know, I was hoping the video would run, but let me, since I'm here, let me just do the slides live. That means I have to get it open.
Mm-hmm.
Let me check.
In the meantime, yeah. In the meantime, okay, great.
Voice is not.
The voice is not coming.
Oops.
We can't hear you, Bob. We can't hear you.
Yeah, so what I'm going to do, Kestri, I'm going to share my screen. I apologize for this.
Live.
Hi, Ashok. Nice to see you. So this should work. Now you can see my screen?
Yes.
And you can hear me?
Yes, very clear.
Okay. All right. I'm sorry about that, but I'll be glad to do it live because I'm here. I hope the connection is good. I'm sitting here in Oregon looking out at the ocean. It's beautiful. So Pallavi Singh, the incoming fellow, and I would like to review orbital decompression. I'm sorry that I can't be with you all in Delhi. So many of you have become close friends, and I really love coming to India. So hopefully we'll be there next year. And I wanted to thank Ashok and Santosh and all the organizers for inviting me. And thanks, Kasturi, for leading this beautiful session. All of the material in this book is more detailed in Milind Naik's very nice textbook, and I'll refer you all to that. So when I was a fellow, orbital decompression was for the very worst cases of thyroid eye disease. But what we've learned is that repositioning over the prominent globe is not ideal. And really for optimal functional and aesthetic rehabilitation of these patients who have so severely lost their self-confidence and quality of life because of the changes in the eye disease, we have to develop techniques that maximize the aesthetic and functional reconstruction. But in doing that, I think it's critical to reduce the risk of complications, particularly new onset strabismus, which I think is the most important realistic risk of decompression. Now, orbital decompression is not complicated science like Ray Douglas is going to talk to us for a moment about this, spectacular biological therapies that are coming online. This is really more like carpentry. It's 100-year-old or 200-year-old techniques. And there's just two bony surfaces, really, the medial orbit and the lateral orbit that we can use. Now, the anatomic accesses traditionally were claimed by the specialty. So the neurosurgeons would come in from above, head and neck from below. Ophthalmologists would take off the lateral wall. But all of these areas of bone can be safely and completely approached from orbital ophthalmic approaches, hidden incisions. As we think about which of those walls to use, I suggest that the paradigm should be which approaches cause the least strabismus. Now, the worst approach for strabismus is the unbalanced inframedial, some studies showing 30%. Inframedial sparing the strut is bad, but maybe a little bit better. Balanced lateral and medial is even better. Deep lateral wall alone is better still. And fat-only decompression is probably the best in terms of strabismus. So when I approach orbital decompression, I start with orbital fat in all cases, then add the deep lateral wall for additional decompression, the medial wall, which includes the posterior floor, and then finally the rest of the orbital floor is rarely used. And by removing all of these areas, we can achieve sometimes 5 or even 9 millimeters of proptosis reduction. But having said that, let me emphasize a few things that have occurred to me as I get more gray hair. First of all, I've learned that proptosis reduction is not the only important outcome. And these patients have this pressure pain, congestive orbitopathy, and relieving congestive orbitopathy may be the most valuable benefit of orbital decompression, like this patient here with all this swelling pressure pain who feels much better after even a small decompression. The other thing that I've noticed is that now that I've taken care of patients for a long time, I'm starting to see late enophthalmos more and more. These patients come in 5 or 10, or sometimes, I hate to admit it, but I have 20-year-old patients now, 20 years out. And they come in with this late enophthalmos because I think the disease unwinds a little bit over time. I'm not sure if you've found that, Santosh, but that's something that I've been noticing. And so I'm more conservative, especially in young patients. I decompress them enough to make them comfortable, but I don't necessarily try to get them all the way completely to normal because I think the disease in many cases will unwind a little bit more over the years. So let's focus now on the actual techniques. Orbital fat is removed in all patients. A lot of times I do this with local anesthesia and remove a little bit of the bone in the zygoma, what I call the basin of the infraorbital fissure. And the technique that I use is really like a suction cautery. So I'll take a 10 French, well, first of all, here I'm removing a little bit of that zygomatic bone. You can use a curette or a drill for that. And then with a scissor, I gently spread the fat intraconally. That allows it to be teased up into the suction. And then with just a little bit of cutting and with a lot of suction, we can remove a substantial amount of the intraconal fat. The second wall is the deep lateral, what I call transorbital transcranial. Now, I said earlier that ophthalmologists traditionally removed this zygomatic bone, the orbital rim. But I don't like, first of all, removing that rim doesn't create that much decompression. Second of all, the eyes move out as they come forward. Tanuj Nakra showed that in his forward. And so that after the proptosis is resolved, the eyes come back in. We don't want the eyes to move out. And so I protect this bone, especially over Whitnall's tubercle, to try to prevent that externalization. And instead, the valuable bone for lateral decompression is this body, the thick bone of the sphenoid that you can see here on transillumination. That was the bone that used to be removed by neurosurgeons, but we can get to that effectively through just a simple blepharoplasty incision. Now, what do we do about the lateral wall itself? Early on, I used to try things like a valgus rotation. And some authors recommend just removing the wall. I'm here to tell you, and I'll be interested if the other authors have comments at the end. I don't like removing the wall. And even though people go to meetings and they say they don't see a deformity, I have patients come to me after lateral wall removal elsewhere. And what I see is this hourglass change and loss of support for the canthal tendon. I don't believe that this is an ideal aesthetic maneuver. And so instead of removing the wall, what I like to do is to carve it from the inside. So I make what I call a lacrimal keyhole, and then I follow this river of sphenoid diplo back into the deep orbit. This is all done with a high-speed drill. A rough diamond drill is particularly good for working in the diplo. The rough diamond creates a little bit of heat and allows us to work effectively. Now, in terms of the incision, I used to use the coronal incision, but and you get very nice wide exposure from that. But what I've noticed is that in those patients that I used to do coronal incisions, or even an open lateral approach where you take the muscle out, like Jeff Rose, I know you like to do that, I have seen temporalis wasting. And it's not necessarily the first year that it comes in, but you see it later on. And so that temporalis hollowing, I think, occurs with any manipulation of the muscle. And I prefer to leave the muscle intact. Here's another patient with that temporalis wasting after manipulation of the muscle. So I use a blepharoplasty incision, and then we go back and lift the periosteum off the lateral orbit. And then that allows us access to the deep bone that can then be drilled out in stages. We've published that we achieve substantial reduction of bone in the deep lateral orbit. In fact, when you look at it, at least in theory, just in the lateral orbit, there can be from 4 to 7 cc's of bone available for maximal decompression. And importantly, our studies have shown that the rate of consecutive or new onset strabismus is low with lateral orbital decompression. Now, one thing that I've done differently is that I've started to take out the bone back to the dura. I used to just eggshell the bone to the middle cranial fossa. But then Yi Wang is a colleague of mine in Beijing. He visited us, and he said that he finds that removing the lateral wall actually back to the dura improves the decompression. We did a study, pre and post-op CTs, and what we found is exactly true. Here's a case before and after, and what you can see is that the orbit has, in fact, taken over that space that used to be the bone. The orbit expands into the middle cranial fossa. So now what I will routinely do for the maximum decompression in young patients who need maximal decompression is I'll go back with the diamond burr and we'll expose the dura of the middle cranial fossa. This can be safely done working slowly with the burr. In a young patient, the risk of a leak is very low. And in fact, small CSF leaks laterally are really sort of inconsequential anyway. I send the patients home even if they have a leak. I don't consider it a major problem. So here we've exposed the dura, and then there's other maneuvers that you can use to expose or to remove that last bit of bone. Once you have the dura exposed, you can use a rongeur and remove the rest of the greater ring of the sphenoid to expose a substantial amount of the middle cranial fossa dura. And by the way, this approach is also useful for deep orbital tumors that involve the junction of the orbit and the cavernous sinus. So it's a good technique, understanding how to do this transorbital, transcranial approach. Now the next wall, second wall, is the medial wall. And everyone, I think, in the audience understands that takes advantage of the maxillary and ethmoid sinus. The critical anatomy here is the roof of the ethmoid sinus, the fovea ethmoidalis. I tell my fellows that we don't have many opportunities to kill patients in orbital surgery, but one of the few that is pretty reliable is if you come up and damage the anterior cerebral artery, which rests just above the fovea ethmoidalis, and that can lead to serious intracranial complications and death. So our fellows are not allowed to go into the operating room until they can show me in the cadaver lab that they can very confidently identify and spare the fovea ethmoidalis. Now, I don't know who Lynch was. Maybe Mike or Jeff probably knows who Lynch was, but I don't know why he got his name on that ugly skin incision if Henry Bayliss can't get his name on that caruncular incision, which has been our mainstay of treatment for the medial orbit since the 1980s. And I think most of you use this now. It's an elegant approach to the medial orbit that allows us to get right back to the medial wall in 5 minutes or so. The critical anatomy for the caruncular approach is the lacrimal system. And so you must be able to identify the posterior lacrimal crest here to be able to come in deep to the lacrimal sac and canalicular apparatus. So the surgery starts with a little incision in the caruncle. I'm going to just make a couple of points here that I think are very helpful when I'm teaching residents. First of all, I encourage them to make a wide conjunctival incision, at least from puncta to puncta, because the incision heals effortlessly, so there's no reason to fight the incision. Then we identify by palpation the posterior lacrimal crest. Here the scissor tips are on the posterior crest, and now we can spread on the posterior crest, as seen here, and place a malleable retractor right along the scissors, protecting the orbital septum. That allows us to see this anatomy of Horner's muscle, the posterior lacrimal crest, and we can be confident that we're sparing the lacrimal sac. You can see that nicely on this video with the cotton tip. I clean a little bit of the tissue, and you can see the pink Horner's muscle and the white condensation of periosteum. The next important step is to make a wide periosteal incision. People make a mistake, I find, of making a small incision, but if we make a wide incision from roof to floor, that spares the fat and provides good access to the deep orbit. I usually start with a little cautery because there's often a vessel right at the posterior crest. And then using the sharp tip of the Freer elevator, I cut the periosteum from the roof down to the floor, a sharp, wide periosteal incision. And then that allows us to work back, and now we can lift the periosteum off and easily get back to the ethmoid artery. So here's that wide periosteal incision, and now we can see the ethmoid artery, which can be cauterized or left hanging, depending on the needs of the case. The caruncular approach allows exposure of the roof and the floor, for example, for a big orbital fracture. And importantly, it allows us to get back to these posterior-most ethmoid air cells which are important for optic nerve decompression. I won't discuss endoscopic decompression, but I do think that for the ophthalmologist who's interested, this is a technique that can be learned and provides nice access to the medial orbit. The posterior floor, I'm calling it the third wall, but it's really part of the medial decompression because this is safe bone at the posterior limit of that ethmoidal maxillary strut. Once we remove the posterior strut, we're looking at the face of the maxillary sinus and the ethmoid sinus, and between them is this triangle of bone, which is the junction of the maxillary and palatine bone, and that can be removed for good inframedial decompression. And in fact, sometimes the palatine bone is aerated. Jonathan Kim did his fellowship thesis on this, so we call that the air cell of Jonathan Kim. And when that's present, as seen here on the scan, that provides a really nice, safe area for inframedial decompression all the way back to the palatine bone. Let me finish by concluding that surgery is graded based on the amount of proptosis and congestion. So for congestive orbitopathy, I talked about these patients who have the pressure, pain, and swelling. I often do minimally invasive decompression, which can be done under local anesthesia, outpatient, like an extended blepharoplasty. And we get substantial relief in compression symptoms and improvement in the appearance. For the next level up, moderate proptosis with a woody orbit, then I'll go to the lateral wall. And there we're talking about getting anywhere from 3 to 5 or sometimes 6 millimeters of decompression. For worst cases, March proptosis, very woody orbit, I'll go to a balanced lateral and medial decompression. Here we're looking for maybe 6 to 7 millimeters of proptosis reduction. And finally, for isolated optic neuropathy, I often, under local or general anesthesia, just through a cruncular approach, go right back and open up the posterior ethmoid air cells. Important to go all the way back to the optic canal strut so that you can be confident that you've adequately decompressed the deepest part of the orbit. For non-Graves proptosis, I also utilize decompression. In those cases, I'll often take that intraconal fat that I remove and then use it to build up the lateral orbit. For example, in this patient with high myopia, so that we actually build up the soft tissues as well as moving the eye backwards. That's also a useful technique for blepharoplasty patients, post-blepharoplasty retraction in the prominent eye patient. Another patient here with a prominent eye seen after orbital decompression on the left with repositioning of that orbital fat into the relative hollow along the orbital rim. So to summarize, we talked about a paradigm: orbital fat, lateral orbital wall, medial wall, and finally the remainder of the orbital floor in that order. I said the congestive orbitopathy responds well to decompression and is an important indication for surgery. A minimal incision graded approach is designed to avoid scarring and minimize strabismus. And we talked about this graded surgery. There's no rote approach. Every patient needs and deserves a customized approach. I hope, Santosh, that was a useful overview and case study, and I appreciate the comments of the speakers. And by the way, with luck, I've always said this in my career, that we could get put out of business with better medical treatment. We may be getting close to that, but at least for the time being, there's still a role for orbital decompression surgery.
Wonderful talk, Bob. Best ever.
Excellent, Dr. Bob. So can we get a comment from Dr. Abhijit, please? Dr. Abhijit, are you here?
Yes. Yeah, the decompressions definitely, at least in my sort of patients, we don't get to see a lot of severe thyroid ophthalmopathy. Most of our cases are majorly mild and moderate. So for the part where I'm practicing, our patients who require orbital decompression are very, very far and wide. And I don't really see many patients who require a decompression for optic neuropathy, most of them resolve with medical management. And that is basically a pulse methylprednisolone that we use.
Great. Bob, would you like to comment, please, to Dr. Abhijit?
Yeah, so that's a very good experience. And I think that you've reflected what I feel is the most important aspect of all surgery, which is individualization and understanding the needs of the specific patient.
Great. Thank you very much. So next, now we go to the next topic, please. Dr. Gunjan, are you there?
Yes, ma'am, I'm there. So it is my privilege to introduce my teacher today. He is none other than Professor Pradeep Sharma, who is an internationally recognized strabismologist and heads the strabismus and neuro-ophthalmology subspecialty at Center for Sight, New Delhi. But before that, he was the professor and head of strabismus and neuro-ophthalmology services at RP Center, AIMS, New Delhi for several years. Sir has been an excellent teacher and has more than 200 publications. He is the author of the famous strabismus book, The Strabismus Simplified, which is actually like a holy book for all the strabismus students. And Sir has received various national and international awards, which includes the famous NAPS oration also. Over to you, Sir, for your wonderful lecture.
Yeah, is that there?
Yes.
Thank you.
Yes.
It's a pleasure to be in a group. And as I said earlier, it's my first TED talk, with the pun intended. So it's a great pleasure to be amongst the oculoplasty people, the lone ocular motility person being here. So, and my talk comes in the order in which the strabismus surgeon is called in for thyroid eye diseases. So I think it's quite in order that we know that by now all these things have been talked over. What's the cause of thyroid eye disease? The epidemiology, which is hitting more of the older people and more females, predilection being there. And it can occur in hypo, hyper, or the euthyroid states. We know that the pathophysiology has been talked about, and there are good medical treatments which are on the horizon, which will probably make the life of the thyroid eye disease individuals much better in future. Of course, they are very costly at the moment and not available in our country. We all know that the major problem is with the extraocular muscles, and these are the reasons why they may be causing proptosis as well as this thyroid optic neuropathy, or even strabismus by itself. This is an individual who had come to us. He has a bilateral restrictive strabismus. There is a limited elevation and a marked esotropia. And the interesting part was that the esotropia is worsening in up gaze, probably because of a co-contraction, just like what you have in Duane's retraction syndrome. The superior rectus is working against a tight inferior rectus, which causes a increase of the esotropia, which is happening. So these are the details of the ocular motility of this individual, who was also a gardener by profession. And so his field restrictions were very important for him. We saw that there was about a 35 prisms base out ESO, and which became more in the up gaze. And on doing the force reduction test, we had, could see that there was a tight force reduction test, both for the inferior recti in both the eyes and for the left medial rectus in the left eye. So in such a situation, we went about doing the inferior rectus recession. But since we are doing bilateral inferior rectus recession, which are supposed to be adductors, we need to compensate for the loss of the adduction, which may happen and cause a worsening of the A pattern, as was already there in this. And we did a nasal transposition, and the minimal amount of IR recession required as per the FDT, which happened to be 4.5 millimeters in this case, was done. The medial rectus recession was also about 5.5 in this case, and we had also upshifted the medial rectus again for the A pattern ESO, which was there. And these are the post-op pictures of this individual, who has now the ESO corrected, and the up gaze is improved because of the inferior rectus recession on either side, and the A pattern has also been taken care of. How do we do, what are we going to deal, and what's the ideal approach was the topic given to me. There is nothing which we can say as ideal, but I would say what is optimal that we can do in these cases of thyroid eye diseases. There is a very nice article which has come in JPOS in this year, and that is probably also the largest and the latest that is coming in the surgical treatment of strabismus in thyroid eye diseases. Let's have the salient features of this. This article is from Bascom Palmer Institute, Miami, Florida. They have a retrospective study on 76 patients in which 87 surgeries were done, 43 on the vertical muscles, 16 on the horizontal, and 28 done concurrently. 50 of these 76 patients, that means 66% were females. The mean age happened to be 62.2 years. The median duration of strabismus was 13.5 months, so which also confirms the fact that mostly the strabismus treatment is little late once the eye and the thyroid eye condition are both stable. 61% of these had a prior orbital decompression done, but we cannot really only blame orbital decompression for the strabismus, because 9 had strabismus only after decompression. The rest had even prior to the decompression being done. 66 of the 87 were tackled by an adjustable strabismus surgery, which is a very interesting thing that we should always note. 42 of the 87 cases had inferior rectus recession done, and 11 of the 87 had the superior rectus recession done. The next common muscle to be tackled was medial rectus, which was 20 in bilateral and 13 in the unilateral cases. What was the motor success in these cases? If we go by the criteria of a prism diopter in primary position, considering as less than 5 for vertical and less than 10 prisms of horizontal deviation, 60 of the 87 cases, that means about 69%, had a motor success. Concurrent was as good as sequential, but there were 27 failures. Now, if we analyze these 27 failures, we can see that 16, that means about 59% were undercorrected and 41% were overcorrected. So there is no simple way of just changing your nomograms. You would have to resort to an adjustable surgery. And as is also seen that in second surgery done, it improved the statistics to 76% from 69%. The sensory success by taking the absence of diplopia in the primary position was achieved in 58%. And again, the concurrent was better than the horizontal, but poorer than the vertical alone. It was improved again by second surgery from 58 to 59% only. So what is the role of adjustable surgery? As I said, it was 66 cases were done. It was seen that 67% were of the age group being females, and 61.2 were the age group. And these are both matched in the non-adjustable and adjustable ones. The motor success in the adjustable was 76%. So it is as good or little better than the repeat surgeries done when they were non-adjustable, compared to 48% being the success for motor success in non-adjustable group. The sensory success again was 61% in the adjustable group versus the non-adjustable being just 47%. So it's definitely a role of doing an adjustable surgery. Way back in 2003, I happened to be in Wales for my fellowship, and we had done a paper with Dr. Robert Renicky, who is talking about single stage adjustable strabismus surgery. In this article, we had 7 cases in which this thyroid eye disease was being tackled, and the inferior rectus was done. And it is seen that there is a possibility of progression of the overaction of the inferior rectus. That means the slippage of the inferior rectus is one problem which we have to be taking care of. So when we do the adjustable surgery, the differences in our surgical approach would be, we mark it the same way, but we will pass the needles, leaving a space for our adjustment. I usually prefer to do a hemi hangback and not a full hangback, which prevents the collapsing of the muscle, and we can have a more proper placement of the muscle. And also remember that in this case, for medial rectus, a vicryl suture has been used, 6-0 vicryl, but for the inferior rectus, the recommended suture would be a 5-0 ethibond, which is a non-absorbable suture. as we talked about, that there will be a progressive overaction or recession in cases of inferior rectus. The adjustable strabismus surgery can be done by two different techniques. You can do either by the slip noose technique, or you can have a 1.5 knot, which can be released and corrected. So in the COVID times, I think we are very familiar with these masks. Just to remind you that the sliding noose is like one kind of mask, which is on the left-hand side, and the 1.5 knot is the other kind of mask that we are using. Both can be used as per your choice. Intraoperatively, we can adjust as per the force reduction test. And as Dr. Reneke had mentioned, a single stage adjustable surgery under topical anesthesia or IV conscious anesthesia using midazolam and fentanyl. But most commonly, we are using the double stage adjustment, that is after 5 to 6 hours of the first surgery, that the adjustment can be made. Dr. Rosenbaum used to do after 24 hours. These are this is Dr. Rosenbaum, who is no more with us. And so the adjustment can be done after 5 to 6 hours. And as I said earlier, that almost half of the cases would be requiring adjustment, and we don't know whether to over or under do, but only do it on the actual adjustment basis, that we can ensure a diplopia-free position to the patient. So to conclude my talk, I would like to say that we need to look for stability. First of all, the systemic stability and also the ocular stability before we venture into a strabismus surgery. Secondly, we look for the involved muscles. And third, look for the force reduction test preoperatively, intraoperatively, and also at the end of the surgery, we should ensure that the FDT is free. The plan could be concurrent or it may be sequential, preferably a concurrent one, because both the horizontal and vertical muscles would be involved, and it is better to give a diplopia-free position to the patient using on both horizontal and vertical muscles. Adjustable is preferred. And for the inferior rectus, I would say that we should use a 5-0 ethibond suture to prevent the progressive overaction. This probably is also because the superior rectus may be tight and the inferior rectus, which has been recessed, can fall back, working against a tight superior rectus. Also because of the Bell's phenomenon, which consistently rolls the eyeball up, and the inferior rectus is always likely to be recessed more and more. So a non-adjustable suture would be preferred for the inferior rectus. And a nasal shifting of the inferior rectus should also be done in cases when we are doing bilateral IR, as there would be a pattern exo if we do not do this. So these are the take-home points which I would like you to go with this. Thank you very much for giving me this opportunity. Thank you all.
Thank you, sir, very much. It was such a wonderful talk, and every time we listen to you, we learn so much, as you really make strabismus so simplified. So I think without wasting much time, we'll go to the next speaker. And here I introduce my very good friend, Dr. Milind Naik, who is an expert in cosmetic and reconstructive surgery of the eyelids and face. He completed his training in eye plastic surgery at Steen Eye Institute, UCLA, and is now a full-time consultant at the prestigious L.V. Prasad Eye Institute, Hyderabad. He is an adjunct professor of ophthalmology, University of Rochester. Dr. Naik is known for his minimally invasive eye plastic surgery, the cosmetic eyelid and the facial procedures, and also the thyroid eye disease. Over to you, Milind.
Well, thank you so much, Kasturi, for the kind introduction. Are my slides visible?
Yes.
Well, at the outset, I would really like to thank AIOS, Dr. Namrata Sharma, and particularly Dr. Santosh Honawar for including me in this wonderful webinar. It's really an honor and privilege to be present amongst several of my teachers and guides and mentors. So my topic today is to talk about lids, last but how. And as the title suggests, it's about the eyelid concerns in thyroid eye disease. So most of what I'm going to speak about has been mentioned and derived from the textbook that we recently published with Springer. So as we all know, the thyroid paradigm is to initially tackle proptosis, and then you take care of motility. And third comes the eyelid. And finally, the last paradigm is to deal with aesthetics. So most of my talk is going to hover on these last two areas. So in today's theme, I'm going to talk mainly about eyelid retraction, then a little bit about ptosis in thyroid eye disease, and also the aesthetic aspects pertaining to the eyelid. So talking about retraction, if we were to look at the upper eyelid retraction, it can be simply graded as mild, where the lid is at the upper limbus, moderate, whereas it's up to 2 millimeters of scleral show, and severe when it's more than 2. Similarly, the lower eyelid retraction can be graded as 1 mm, 2 to 3 mm, and more than 3 millimeters. So retraction in thyroid eye disease has to be dealt slightly differently if you are looking at active versus inactive disease. So in active, the options that we have are either botulinum toxin or a filler gel or even triamcinolone. And if we look at this table which summarizes each of these components, botulinum toxin is primarily effective in the inactive phases or towards the end of the active phase of the disease. And an average dose that has been reported in multiple publications is 5 units. And this does give us a fair amount of relaxation for a couple of weeks, but ptosis and diplopia can be a concern. Hyaluronic acid gel can be used for upper as well as lower eyelid. It has a longer lasting effect, and it is reported to be more effective in active disease where the fibrosis hasn't set in and you probably might be able to stretch the muscle to lengthen the eyelid. Triamcinolone, again, as you would guess, it's more effective in the active disease. 10 to 40 milligrams is your dose, and the effectivity would be for 2 to 4 weeks. And this was touched upon earlier as intraorbital injections in active phase. So here is an example of a young male 3 to 4 months down the line in the thyroid eye disease. You can see that the left SRLPS complex is slightly thicker. And since he had a marriage coming up, we just reduced the eyelid position with a botulinum toxin transconjunctival injection. Another example in a bilateral case, obviously these are going to last only for a couple of weeks. Here is a lady with the right upper eyelid retraction, mild to moderate, with a down gaze lag, and she was treated with a single triamcinolone injection into the superior orbit. HA-gel I've used very rarely, but this was one particular case I remember where we had a transconjunctival injection. The result is not perfect, but it has dropped the upper eyelid down. However, in these patients, I do see in down gaze a slight hump, which is created because of the filler injection. Now, tarsorrhaphy can be a very good tool, especially in active phase of the disease. And we do occasionally see patients with infectious keratitis. And those are the cases where tarsorrhaphy would be useful. Retraction in inactive phase, the options we have are millerectomy, then levator recession surgery, and a full thickness blepharotomy. Although before we talk about them, I feel that an extreme lateral tarsorrhaphy is a very good option in cases which have a mild temporal flare and also a lower eyelid temporal flare. These patients, it's very predictable and easy to quickly do an extreme lateral tarsorrhaphy. Mueller muscle options include either just recession, or there is a described recession with suture to fix it to the levator, and the third is millerectomy. And here I'll quickly go through millerectomy steps where you evert the upper eyelid. You get into two planes. One is between the levator and the Muellers, and the other is between the Muellers and the conjunctiva, and simply excise the muscle. So everted eyelid, transconjunctival infiltration, then incision at the upper edge of the tarsus. You're separating the Mueller's muscle here. So it's being separated from this white looking levator muscle. So that's the Mueller's and the conjunctiva. That's the second plane you're dissecting. And finally, the Mueller's is separated from the levator and conjunctiva and excised along its entire width of the lid. And you can see that the instrument is clearly visible here, indicating it's only conjunctiva. I use fibrin glue to fix this. And this is a patient who was not concerned really about the inferior scleral show or the mild proptosis, but she just wanted the upper eyelid corrected. And in her case, we chose this millerectomy. With levator, we have options of either recession alone or recession with a spacer. Spacer is not particularly my personal choice. So here is a lid crease incision, infiltration. We reach up to the levator, that's the tarsus and the edge of the levator, and we are separating the edge of the levator from the tarsus in a graded manner as we assess the patient's lid position on table. Very useful to do this under local anesthesia. Here is a case with right upper eyelid moderate lid retraction with down gaze lag and a slight temporal flare, which was treated with anterior approach levator recession. I prefer an anterior approach over the posterior to minimize the tarsal plate show asymmetry. Full thickness blepharoplasty is obviously the final option in this graded response that we have, where you expose the levator and you ultimately create a full thickness cut from the skin to the conjunctiva, leaving a small bridge of conjunctiva in the center to maintain the contour. And here you can see the lid position has dropped to the level that on table you felt discomfortable. This is a patient who was treated with a full thickness blepharotomy for the eyelid. Lower eyelid retraction can either be bilateral symmetrical or unilateral asymmetrical, or it could be secondary to a strabismus surgery. And in these cases, you can do a retractor release plus or minus spacer. And in some cases, I also choose a preferential anterior floor decompression, especially if it's bilateral. A forced upward traction test, which Bob taught us, is very useful to assess a tight IR, tight retractor, and retractor release would be a choice here. This is a patient who had bilateral lower eyelid, slightly asymmetric scleral show, and this she was treated with lower eyelid retractor release. This case, not really thyroid, it's a unilateral high myopia. Here also we did a retractor release with traction sutures combined with an extreme lateral tarsorrhaphy to give her symmetry. So these are just steps of lower eyelid retractor release, where initially you see that the instrument is not visible, the scissor below, because there is a retractor and conjunctiva. And then I'm getting into the plane between retractors and the conj to ultimately leave only conj here, and the retractors are recessed. Choosing floor as a decompression option is a given when you have a 3-wall decompression, but in some cases where it's a 2-wall or a choice, I would preferentially choose floor so as to reduce the extreme amount of scleral show. So here you can see the canthus is hitting the limbus, whereas when you move the eyeball down, it's practically hitting the lower end of the pupil. So the eyeball is moved down because I obviously cannot move the eyelid up through a degree of 3 to 4 millimeters. Talking about ptosis, it's always been the upper eyelid retraction which has stolen the thunder about diagnosing thyroid eye disease, but we do see a lot of patients who come with ptosis. And although our first reflex would be that myasthenia should be the diagnosis there, we find that 2/3 of these patients are aponeurotic, and it's more common in fat disease than in muscle disease. So maybe the fat acts like a increased orbital pressure, which kind of tends to detach the levator from the tarsus. So here is a case which had mild proptosis along with levator disinsertion, and there was a combined surgery performed. Finally, coming to the aesthetics, if you look at aging versus thyroid eye disease, because of the corrugator overaction, you would have glabular furrows. The brow fat pad is increased in these patients. Here you can see the medial fat pad too. So for the glabular lines, you can either use botulinum toxin, or if they are static, you can use fillers. Here is a case where the lower eyelid tear troughs were treated with a filler injection in a patient with borderline thyroid eye disease. Here, this slide is particularly to show you that when we focus only on proptosis reduction, we actually aren't really changing the aesthetics of the eyelid. So here I've gotten a reduction on either side, but the patient isn't particularly happy. Even though the lid recession surgeries are pending, she's still concerned about this fat in the upper eyelid. So combining these things probably is the best way to go. Negative vector is something which we have to keep in mind whenever we are planning lower eyelid surgeries in thyroid patients. These are cases where a mild tear trough after the rehabilitation can be treated with filler injections. And if the proptosis is very mild, you could just get away with a blepharoplasty. Lacrimal gland prolapse is rare but is possible, and this has to be kept in mind, especially in cases who have mild proptosis, who don't really want the decompression. And these rare occasions, you might have to do lacrimal gland fixation. Subconjunctival fat prolapse, although not really an eyelid issue, can be a cosmetic concern, and this just needs transconjunctival excision. Finally, the last slide, which talks about multiple ways in which premalar and cheek swelling and fluid accumulation can be very frustrating, and I haven't yet found any useful method of treating these. So just to summarize, we talked about lid retraction, ptosis, our experience, and few aesthetic issues pertaining to the eyelid. And all these again are covered in 3 chapters in our textbook. Thank you very much.
Thank you, Dr. Milind, for such lucidly describing all the lid options. I'll request here Dr. Lakshmi Mahesh to comment on the lid options and Dr. Milind's talk. Dr. Lakshmi Mahesh is past president of OPI. Dr. Lakshmi, please, are you here?
Thank you, Mukesh, and thank you all. Milind, it was a very good talk. More than commenting, because I don't have that much of experience in eyelid surgery, what we aim is mainly to take care of the dysthyroid optic neuropathy and decrease the proptosis. See, one point I would like to make is we're having a lot of patients with hypothyroid and euthyroid eye disease. So that's one very important point I would like to make. And radioactive iodine, the cases where that has been given, they become grossly hypothyroid and have very severe eye disease. So that is something which in our Indian subcontinent we have to really keep in mind. And IVMP, we were talking about 4.5 to 7 or 6 milligram dose. I go, sometimes I've even gone up to 18 in different cycles. And I think we have, Indians have very tight orbits. So we have to bear that in mind, that we can easily go in for dysthyroid optic neuropathy, and we definitely tolerate the steroids. Of course, judiciously, I take the help of an endocrinologist and who monitors the sugar levels. And block treatment is another thing which works very well in our patients. Rather than just treat only the hypothyroid status, when we start the block treatment, they do respond very well. So when it comes to strabismus or eyelid surgery, the number of cases which I do see are very few. And eyelids, I do a blepharotomy as such, but invariably, at least 60% of the patient land up with some amount of ptosis. So they present with an eyelid, gross lid retraction, then we land up with a ptosis. So I'm really scared of doing these surgeries unless and otherwise the patient is euthyroid for quite some time and has no other comorbidities or vision. Thank you.
Thank you.
Thank you, Dr. Lakshmi, Dr. Milind. So now we'll go to the last talk of today's session, and this is by none other than Professor Geoff Rose. Dr. Rose has graduated in medicine in 1979 and is a member of the Royal College of the Physicians. During ophthalmic training, he received fellowship of the Royal College of Surgeons and the Royal College of Ophthalmologists. He has been a director of the NHL service and is now the senior consultant at Moorfields Eye Hospital. The unique case mix has fueled research for many publications. He lectures widely, has presented various named lectures, and received a very prestigious the Lester Jones Anatomy Award from ESOPers. He is the past president of ESOPers and the British Oculoplasty Surgical Society. So over to you, Dr. J.
Thank you. Just trying to find my desktop. Sorry. Right. Hopefully. Can you see a screen?
Yes.
Good. Right. Can you all see blue screen?
Yes.
Right, lovely. Thank you. So last word, really 10 pearls that I've learned with thyroid eye disease over looking more after these patients for more than 30 years. Some things have been covered, but interestingly, some have not been covered during the meeting. So hopefully there'll be useful pearls. Perhaps the most important is there is no stereotype for thyroid eye disease, and I think that's come across very well in the meeting. But the first pearl really is lid retraction plus. You know, upper lid retraction is generally due to levator overaction in the active disease and fibrosis in burnt out disease. It's the traditional teaching. But the key word there is the fibrosis in the burnt out inactive phase. And unfortunately, thyroid eye disease or muscle inflammation isn't the only cause of fibrosis within the superior rectus levator complex. And so here is a patient who did have thyroid problems in the past, developed upper lid retraction, but in fact, it was down to breast cancer with breast cancer cells and a scirrhous response within the levator. So keep a watch out for additional diseases, even when they have thyroid problems. Both of these patients had thyroid problems and both had irritable eyes. This lady, both eyes irritable, this lady, an irritable right eye. But don't miss these sort of subtle things like lid retraction hidden under a bit of brow descent. Very easy to overlook the retraction as a cause for the irritation. And in this young lady, as mentioned in Mylin Nake's talk, which was lovely, you know, you may well miss the fact that she actually has a ptosis, and her prime problem isn't the retraction. Her prime problem is the ptosis, despite previous thyroid abnormality. So, second thing is the red eye in thyroid eye disease. And red eye in thyroid eye disease is due to the inflammatory dilatation of blood vessels and or the raised episcleral venous pressure. And here in particular, this has been brought up before, we have a real problem with a rise in pressure in the orbit. And so this patient developed red eye over a few days, red eyes, and had a previous problem with overactive thyroid, but had been controlled for quite a long time. And it just didn't seem to settle. It didn't quite fit. It was somewhat red, somewhat congested orbit. And in fact, what she has is a low flow dural shunt. This is another patient. They don't look the same as the vessels within thyroid eye disease. With the shunts, they tend to be much more snaky, and obviously the scan will show diffuse enlargement of the muscles, very similar to thyroid eye disease. You may have a small rise in pressure in the eye, but the giveaway is the large vein with the change in flow on ultrasound, Doppler ultrasonography. Another thing not to be missed, which has been brought up before, and often these patients have been on steroids for a year or 18 months because they all the time look slightly inflamed, slightly red, swollen, variable swelling, but great snaky vessels, which again makes you think, is there a shunt? But in this case, it is pure hydraulic thyroid eye disease. The pressure at the back of this gent's orbit is massive. He had a pressure of 35 millimeters of mercury despite using several topical medications. And here he is literally after decompression, very soon after. Here he is after 6 months, and here he is after a year. He was off medications for his pressure almost immediately. And notice he's actually not had any blepharoplasty at all. So a lot of this leakage of fluid was pure passive leakage due to the dilated episcleral vessels. And these patients with dilated episclerals due to hydraulic disease need decompression. Third pearl, chemosis and redness in thyroid eye disease. The red edema of the conjunctiva and or lid redness are due to leakage from inflamed vessels in thyroid eye disease. Well, the answer is not always thyroid eye disease, even in patients with thyroid problems. So this chap was on thyroxine and developed irritable eyes, but in fact it turned out that it was an itchy redness and he was allergic to ivy and was not actually thyroid eye disease that he was originally thought to have. This patient, again, thyroid abnormality, had been thyrotoxic several years before, with really quite marked prominence developing more recently. But the giveaway was his peripheral neuropathy, a sensory neuropathy and wasting of the muscles. And when he took a biopsy, yes, he has big muscles in his orbit, but he also has fluffy infiltrates, and he actually has sarcoidosis, giving the peripheral neuropathy and the orbital problems. This lady also had been hypothyroid and was on thyroxine, apparently well controlled, started developing problems. She had leukemic deposits. And just remember, inflammation is a tissue response and not a diagnosis. Other things like bisphonates can induce orbital inflammation and can confuse the picture. The fourth pearl, big muscles and thyroid eye disease. Obviously, large muscles are generally due to thyroid eye disease, as we see pretty typically, but beware of the single large muscle. It always makes you slightly unhappy, or if you've got a lot of really, really big muscles. So for example, here, a typical sort of myositis, single muscle, but it could be something else. This girl had had thyrotoxicosis in the past, but that was quite a long time back. But she started developing diplopia, as you can see, and she had several large muscles, as you can see. But what is unusual is that she has an exotropia, or an exophoria, and limited adduction, in other words, a tight lateral rectus. And with her pain, this is clearly an idiopathic myositis rather than thyroid related. This patient presented with an apparent thyroid eye disease and bigger muscles, but in the end we took biopsies and it turned out that she had a neuroendocrine deposits within the muscle. One thing which you may not have met before, I call it the amphora sign, as in this gent, with a general reduction in movements. He was hypothyroid and on treatment, but when you took a scan, things just weren't quite right. It's what I call the amphora sign. Suddenly the muscle narrows down from a relatively large muscle extremely rapidly, like a Greek amphora. And that is not uncommon with tumor infiltration, in this case lymphoma, and same thing in the lateral rectus, this sudden narrowing, the amphora sign. So look out for that. It's a very useful sign, tends to indicate muscle infiltration. Fifth pearl is related to optic neuropathy in thyroid eye disease. Remember, markedly reduced vision in TED is not always due to compressive optic neuropathy. Clearly, in cases like this with ocular surface disease, that's readily distinguishable. But if you see a patient with relatively good corneas, but poor acuity, 660, but good color perception and no RAPD, take a really close look for fine macular pathology, like macular striae, a partial thickness or a full thickness macular hole. Or occasionally I've got a handful of patients over the 30 years who clearly had a psychogenic difference between their acuity and their optic nerve function. Sixth pearl, treatment of thyroid optic neuropathy. Compressive optic neuropathy, and this has been brought out by several of the talks, particularly if it's associated with obscurations of vision. This hasn't been brought out at all, needs urgent treatment. If patients with optic neuropathy, compressive optic neuropathy, start getting obscurations, I jump up from bed and my vision blots out for 15, 20, 30 seconds, or I move my eye and the vision blots out. These patients have got critical perfusion of their optic nerve, the arterial circle behind the globe, and they're about to snuff out their vision with an anterior optic neuropathy. And these patients, I've seen one patient get an altitudinal loss just whilst you're waiting to get these patients in to decompress them. So they need urgent treatment if they've not responded to steroids. So here, for example, a 51-year-old lady, tight orbits, she'd had 8 months of TED, treated with steroids and immunosuppressants. But for the last month, she'd started to get postural obscurations. And that's bad news if you don't get on and decompress them. And if you take a look at her scan, not only is she tight at the back, but she is so tight that she's getting the Y sign due to the optic nerve actually pulling so hard on the back of the globe. And so you're getting a critical loss of perfusion around the arterial circle just behind the optic nerve head. These patients with postural obscurations need decompression pronto. Just remember the golden rules for decompression with optic neuropathy. If optic neuropathy is serious enough to persist after high-dose steroids, then apical pressure is still markedly raised. If the pressure is very high in the apical tissues, you need to expand the bone immediately in front of the annulus of Zinn to give it more space where it matters. The only removable bone actually in front of the annulus, hard in front of it, is the medial wall, and the floor near the apex, as Bob mentioned, with the palatine bone, especially if it's aerated, and the lateral wall is somewhat more remote. And so in general, I use inframedial decompression for dysthyroid optic neuropathy. It's extremely quick and very effective, but you must make certain you go back to the annulus. And there is absolutely no indication for decompression of the canal, which is behind the annulus, which people still talk about, totally unnecessary. The other thing is never give up on optic neuropathy before a maximal decompression. I've had a patient come with 6/36, documented well for about 17 years, who came for aesthetic decompression. We decompressed her and she came back to 6/9. Nobody expected it because she had a pale disc. So always give them a decompression. As I say, I do the complete ethmoidectomy, tiny bit of the floor to get up to the canal. So you decompress about 170 degrees of the area. The Mercedes sign, very important, and that's the sign between the orbitomaxillary interface, the orbitoethmoidal interface, and the maxilloethmoidal interface. And I always remove the Mercedes sign, the bone, in that area at the apex. As already mentioned, I use a retrocaruncular approach. I don't go through the caruncle because that heads in towards the gland. I go immediately behind it between the plica and the caruncle, easy to reach the posterior lacrimal crest, and then jump into the extraperiosteal space and down towards the apex. It's a lovely approach. And the closure is so simple. I just put in 2 7-ovicral sutures to stop the fat prolapse forward. And it's a lovely approach. And you really can do a complete ethmoidectomy back to the canal and also remove the critical part of the floor posteriorly and the inframedial strut posteriorly to allow the tissues wide prolapse out and relieve the optic neuropathy. Seventh pearl, aesthetic decompressions for thyroid eye disease. In general, bone decompression does give maximal and the most predictable results. And I, like Bob, I use the lateral wall wherever possible. But you really can return these patients with gross proptosis to their normal position. And here's a lateral wall alone. It heals extremely well. I use the upper lid skin crease, and we can remove the bone and you can grind away there if you want, take more, but you can get 4 or 5 millimeters happily through that approach. I think the most important thing about lateral decompression is that not only do you get a proptosis reduction and it drops the intraocular pressure, but it treats persistent prolapse of the lacrimal gland, which is one of the most troublesome and annoying things. And my Lind mentioned it in his last lecture, prolapse lacrimal gland. Dacryopexy, moving it back in, doesn't tend to help it terribly well. It'll come forward. But lateral decompression, and I do it ab externo, I always leave the rim in place. Like Bob, I think taking it out is a mistake. You can break the bone out and then remove that residual bone, prolapse the fat out, but you prolapse the lacrimal gland back into the upper part. So you create a pseudo fossa, and provided you close temporalis well, you don't tend to get a divot. And I add the medial wall if you really require a lot more decompression, and I avoid the floor as much as possible because it adds a vertical component to the motility problems. And so I try and avoid the floor. And by using 2.5 or 3 walls, you can get back. This chap went back about 11 millimeters. It's this chap on the table, just on the one eye, we're about to do the other. And there's the incision through the lower lid swinging flap. Another example, a gent who went back about 11 millimeters. Talking about big decompressions and squint, strabismus, and the old chestnut is out there that decompression worsens ocular motility and causes squint. Well, that's totally wrong. I've come to the conclusion that it really is wrong. And so much so that I've had decompressions with 40 40 diopters of vertical, and after decompression, effectively, it's gone down to 5 diopters. So take, for example, this huge decompression, let's say about 11 to 12 millimeters. Here he is after surgery, very good motility. Here is his HES before surgery. Here is the HES afterwards. If anything, the overaction is actually better. Okay, you say that's bilateral, so of course it's going to do better. So we'll take this chap with his unilateral, severe left-sided restriction, severe. So he goes back 11 millimeters with decompression, but look at his motility. It actually improves. There's less overaction on the contralateral side, and his motility opens up. So the old chestnut that it worsens motility is wrong. Why does it improve motility? Well, of course, if you've got a restrictive muscle like this, restrictive muscles plus proptosis, you've got a double whammy, a tight muscle that doesn't allow a globe to move when it's already on the stretch. Put the eye back in the right place and you help the muscles. The second thing is that the oblique, the superior oblique, actually, when you've got a lot of proptosis, is heading forwards instead of its normal action, which is from further back. And so that will alter it. So let's get rid of this chestnut that it worsens motility and causes squint. But where does this abnormal come from, this abnormal idea, this incorrect rumor? It doesn't worsen motility, but what it does do, of course, it changes the phoric range so that lateral decompression shifts the patient towards exophoria. Medial decompression, which is so notorious for causing squint, shifts towards esophoria, which you cannot overcome. As a normal person, you can overcome a slightly increased exophoria, but not an esophoria. And removing the floor, of course, flips you into a vertical phoria, which is even worse. Having said that, you can use decompression to your advantage in strabismus. So, for example, this patient with a left hypotropia, really quite severe and quite severe restriction, she needed 2 walls done. So on this side, you do the medial and the lateral wall. And on this side, the hypertropic side, you do the lateral wall and the floor. What is the net effect? Well, here she is before surgery, and here she is afterwards. Still has a vertical squint, but a markedly reduced overaction simply by tailoring the motility. Here she is beforehand, trying to look up, improved up gaze or reduced up gaze on the right, so disparity is less. And here she is in primary position with a considerable improvement. So you can tailor if you're doing 2 walls, you can, on the hypotropic side, do the medial and lateral, and on the hypertropic side, do the floor and the lateral. Remember, don't remove too much tissue in TED. As Bob mentioned, later on, you can end up with problems. And you know, if you take out too much bone or fat, you may get skeletonizing. So here's a girl who was about 32 millimeters exophthalmos beforehand. She did extremely well on one side, but the other, at that point, I was overdoing it, and my mistake. Plus, she got a degree of over prolapse. So lessons learned, don't overdo it. The other thing you may get is late enophthalmos. For example, this chap, here he is after decompression. He's actually symmetrical in terms of exophthalmos. He then had his hypotropia corrected. And then about 18 months to 2 years after, he started getting enophthalmos. And it was due to imploding antrum syndrome. We blocked the drainage of the left antrum. And so it was collapsing on us and dragging his eye back. So leave the anterior part of the infromedial strut. Here's the infromedial strut, the ethmoidectomy, the maxillectomy, the floor removed. Don't take out the whole strut because the antral drainage is just under this area. You can take out the posterior strut safely, the posterior 1/3, but don't take out the anterior. Last pearl of all, correction of thyroid lid retraction. Don't obviously miss secondary lid retraction. And so, for example, pick up on primary lid retraction, which is less in up gaze and more in down gaze, in contrast to secondary lid retraction, which tends to disappear on down gaze, and this is due to a tight inferior recti, and get more on up gaze. So make certain you get them the correct way round. Classical teaching for lid lowering says completely detach the levator from the lateral tarsus and always keep some levator force applied medially. So here, for example, a right side, keeping some medial force and completely detaching the levator from the lateral end. Yes, that drops the lid, but interestingly, after lid lowering, you'll quite commonly still see a degree of lateral flare. And I've often wondered why this was, despite all our efforts to transfer the force medially, why you got this. And it wasn't just proptosis. And so we now use blepharotomy. And so when we started, we were doing this and then go up here to try and stop any effect of this part on the lateral part of the lid. But what I realized a few years back was that, in fact, the lacrimal gland lying there where we were going up alongside, if you got the patient to look up whilst they're under local anesthetic, there's a huge tractional force on the lacrimal gland, despite going up right alongside and beyond Whitnall's fascia. You'll still see the lacrimal gland go up and with it the lid. So I said, okay, if that's the case, and this tends to be a bit uncomfortable, don't bother with that any longer. Just carry on the blepharotomy until it reaches the outer orbital rim. So I just go along there and out to the rim. I control the amount it drops by the degree you move medially. The more medial you go, the lower it gets. And so you can tailor that under local anesthetic. And then when you have the continued force, if you go right out to the rim, you'll see the gland goes up quite happily, but the lid will stay in the correct position. And you can end up really correcting some gross upper lid retractions to a very good contour by using that method. But going right out to the rim, just leave about 3 or 4 millimeters height of the tarsus so that they don't get lymphedema afterwards. So the 10 pearls, remember the mimic syndromes for the lid retraction, the red eye and the chemosis. It's not always thyroid eye disease. Beware of a single big muscle or multiple giant muscles, and keep a lookout for the amphora sign, because that's often malignancy. Look for a disparity between acuity and the color and RAPD in patients with dysthyroid optic neuropathy. It's generally a macular problem that can be hidden amongst the excitement of thyroid eye disease. Inframedial decompression, especially if they've got obscurations of vision, key to decompress them. And remember some of the golden rules that you need to get to the apex. Lateral decompression for aesthetics is preferable because it has a 0 rate, an effectively 0 rate of new double vision. And avoid the floor because that introduces a vertical phoria, which is much harder to treat. Decompression itself does not worsen motility. It actually improves motility of the globe, but it alters the phoric angles. And you can use these altered phorias to help your strabismus surgeon later on. Preserve temporalis muscle, preserve the anterior half of the inframedial strut, or you'll get overcorrections. And to avoid lateral flare after lid lowering, I tend to disconnect the central and lateral tarsal plate from all tissues above it and run right out to the lateral rim. Thank you very much, everyone.
Well, thank you, Dr. Jeff. And thanks once again for bringing out some of those points which are not really stressed. So now I'll request all the panelists and experts and speakers to participate in an open house discussion for 3 to 5 minutes, really, because I think we don't have too much of time. And I'll request our chairpersons, Dr. Grover and Dr. Usha Kim, to take it forward. Grover and Usha.
Question.
I'm sorry that got back to you.
I think it was an excellent session, and we've seen a variety of challenging situations where we all have dealt very differently. So I think, as most of them have mentioned, it has to be customized, and it cannot be a general statement, one rule for all patients. And as was pointed out earlier, I think we've seen different scenarios in different parts of the world. And we can see that variation between the north and south of one country itself. So what's really important is, as Dr. Jeff always points out, he has great pointers. He mentioned that we need to be on the lookout for all the variations and all the alerts, high alerts that needs to be addressed, and the treatment protocol has to be set in keeping in mind all of these points. And we can see the differences in each of the surgeons as to the decompression part, like the variations in which wall to choose and the types of the options that are available as well. And as for the medical management, I think we're still not economically sound enough to get the very expensive drugs which are now being used in the US. But that apart, I think we are good with the biologicals as well. And IVMP does stand very well and does work very well in our part of the world. So we actually do very well with the medical management. And I remember Dr. Abhijit mentioning that we don't have that many cases as to go in for aggressive decompression. But of course, we do deal with a lot of lid surgeries and the retraction. I think this is all I have to say. I'm sure Dr. Grover has something to add.
Thank you, Usha. That was a great summing up. The challenge of thyroid orbitopathy, I think, has been highlighted very well by this galaxy of speakers. And we couldn't have had a better overview. A lot of concepts have been clarified. I've learned a lot. And I'm sure the surgical concepts as well as the concepts about diagnosis and therapy have all been updated and clarified very well. Yes, there does seem to be a significant difference in the spectrum of disease in at least North India, where I agree with Abhijit that the number of thyroid eye disease cases that we see, those that require decompression are relatively smaller in proportion, and it must be something to do with the different anatomy or different genetics. But yes, we do have a significant number of cases, particularly now that the aesthetic indications have become important as well. The lid retraction part remains one of the tougher parts because you don't get consistent lid crease. That to me, and even the results are not always as predictable as you would have in, let's say, ptosis management or something, but the inconsistency of the results makes the management more tough. But couldn't have had a better galaxy of opinion from the best people in thyroid eye disease. And I think I would like to congratulate All India Ophthalmic Society for having brought this galaxy together. Thanks to Santosh, thanks to Namrata. Thank you all very much.
Thank you, Dr. Santosh and the AIOS team. Thank you so much. It was a great evening. I think worth the long hours, and all of us go back with more inputs from everybody. Thank you so much.
Thank you, everyone.
I think with this, we close the session. And good night, good morning, and thank you, everybody.
If all of us can put on the camera, we can take a picture quickly.
Oh, okay.
Lakshmi. Okay, take it. I'll send it to you on a group.
Thank you.
Thank you. Thank you.
Thank you. Thank you. Bye-bye. Bye.
Bye, Sampath.
Bye. Thank you all very much.
Bye-bye.
Thank you and goodbye.